There we go. I see recording has started. Okay, next slide, please. All right, so how to use the ASAM criteria. So certainly one of the things that we saw from the poll, and I know I've experienced this myself, you know, when I first started using the ASAM criteria, it was like, whoa, this is a lot. And where am I going and how do I navigate and what does everything mean? So I'll give a just brief overview of how to use the ASAM criteria. What is showing on the slide, this is also located in the ASAM book. And I would encourage, if you don't have an ASAM book, at some point in time, you will want to get one. It is incredibly useful. Mine sits on my desk every day. When I have the complex cases come up, the first thing I do is grab it and I start going through it to be able to identify what questions do I have, what is it I'm trying to figure out with someone. So when you do get a book, the first thing you'll want to do is go and find this page. And it's at the very beginning and it outlines how to use it. It's only a few pages, so it doesn't take long for you to go through. But as you can see on your screen on the left-hand side, there are tabs that provide a quick reference to specific large content areas of the book. These tabs are the key stages in the ASAM criteria treatment process. So I use these tabs all the time to be able to find the large issue that I'm looking to figure out. Is it that I'm looking at identifying a level of care? Is it that I'm looking at service planning? So that tab on the left-hand side, it's going to help you find your larger issue. And then once you use that tab, it drills down to further areas that you're able to look at. So the tabs read history and applications, intake and assessment, service planning and placement. The tab I use most often, level of care placement, and then lastly, emerging understandings of addiction. I want to point out there are orange boxes that pop up all throughout the book. And it contains, on your screen, it's about the bottom middle of your screen. It's orange boxes that pop up all throughout the book that contain adolescent specific content to any of the items that are being discussed for ASAM or any of the levels of care. So ASAM does break out the adult criteria, and then it also breaks out adolescent specific criteria. You will also find dotted lines throughout ASAM, which indicate section breaks within certain chapters, or it may represent new criteria being discussed or a new population. So just pay attention for dotted lines going all the way across the page, and it'll help you shift your thinking to the new focus of discussion that's taking place. Lastly, throughout the ASAM, they use orange icons to represent service categories. On page 131 of ASAM is where you will find the key for what all of the icons mean. So for example, an orange clipboard means dimensional admission criteria. And again, the reason this and other items, such as the dotted lines and the colored tabs, the reason why the creators of the ASAM criteria did all of this was to use these tools to facilitate reader usability. As Katie mentioned, and I can say for myself, it really just takes time of using the book and being in the book often to get used to where you need to go and what specific area that you're looking for. And next slide, please. Okay, so new terminology for the ASAM. Older editions of the ASAM, they use different terminology. In this edition of the ASAM, it's currently in its 3rd edition. It introduces new terminology. The first bullet point identifies that person served is referred to as an individual, person, participant, or patient. I will say, for the purposes of this training, how we will be referring to people is in non-clinical terms such as person, individual, or person served. And really that just goes back to our philosophy and principles within OCHN. That as a network, we made the change, gosh, 2 years ago, where we really took a more person-centered approach, and we made it a point to not refer to the people we serve as patients or consumers or clients. And so as we move throughout this training, you will see the same. Anytime it might say patient, we change our terminology to say person or individual or person served. Our second bullet point, the ASAM criteria. So it's the treatment criteria for addictive, substance-related, and co-occurring conditions. It's important that I point out that the criteria is more than just placement. That's only one small piece. It's about the full needs of treatment for a variety of conditions. It also provides the framework for the service plan for individuals, as well as the continued stay, transfer, and discharge criteria. Much like treatment and placement, using the criteria is not a one-time event. It is a process. Our third bullet point, the ASAM uses terms such as co-occurring throughout instead of the terminology of dual diagnosis. Dual diagnosis is something that we have certainly used a lot in the past, but ASAM criteria, they prefer the use of the term co-occurring disorder. And the fourth bullet point, opioid treatment services. When we get to this section of the ASAM, this covers more than just methadone treatment, and which is different than the past. In the past, it was referred to heavily as methadone treatment. In the new ASAM, it really works to cover all office-based opioid treatments. And lastly, for level 3.3, clinically managed population-specific high-intensity residential services. This level of care, it's more clearly defined in ASAM to reflect its original intent and purpose. And with that, let me take a pause for a moment. How are we doing with the slides? I see a little bit of chatter. The slides aren't progressing.
Megan, for me, it's showing as the correct slide, but maybe for some people, it sounds like it's not progressing.
All right. Should we take a moment to have that corrected?
That would be something they have to correct on their end, so they may have to leave the meeting and come back in.
Okay.
May just be a bandwidth or a Wi-Fi issue.
Okay, gotcha. Perfect. Okay. So next slide, please. So levels of care, or for shorthand at times, how we write or say it, we say LOC. So as you can see, here are the ASAM levels of care laid out as a progression. But it's important that I point out for you that the level of care placement is actually one of the final decisions to be made using the ASAM criteria. Before the final decision is made, a great deal of planning and interaction with the person served is necessary to determine the least intensive, safest level of care that allows the person to achieve the goals on their service plan. Next slide. So our guiding principles. So listed here are all the guiding principles of the ASAM criteria. Chapter 1 of the ASAM book goes over each of these guiding principles in length. I'll do a brief description and explanation of each for us. So multidimensional, the ASAM criteria covers all relevant areas of a person's life. A multidimensional assessment is the biopsychosocial that's done. So we really want to make sure that when we are meeting with someone, when we are doing that intake, we are getting a clear, well-rounded picture of what is truly going on with them. And that biopsychosocial is what is going to collect that information. Clinically driven treatment. It is treatment that is driven by the person's need, not program design. So often individuals have been placed into predetermined programs, but what the ASAM criteria advocates is that treatment is designed around the person's clinical needs. It's important that programs offer multiple clinical components and that their counselor and the person served, they can build their treatment program together. So at an outpatient level, what this looks like is your outpatient program. It offers multiple different types of groups that a person could do. You can have a relapse prevention group, a co-occurring disorder group, a trauma group. And it's groups that not everyone works through. It is groups that when you sit down and you develop your treatment plan with the individual, you're looking at what exactly is the person's needs. What are they identifying that they feel as though they need to work on? And so to have those different types of groups available allows the person to say, hey, I need to work on this. Instead of, part of the old way at times would be that everyone just progressed at the same time through the same groups. Let's see, same for residential. Multiple clinical groups or program components are offered that allow the person and the counselor to build their treatment program specific to clinical areas that need to be addressed. Next, we have variable length of service. So treatment has often been offered in time-driven programs. Using the ASAM criteria, the length of service should be based on the progress the person is making. One of the things that we did at OCHN when SUD services merged into the ODIN electronic health record system, we took the time then to rebuild the authorization process, and we made benefit plans. And part of what we did with those benefit plans, we took all of the services, we put it into a benefit plan where typically at most it would be 30 days for length of stay that could be asked for. It could be more, obviously, if someone met ASAM criteria, then it might be more than 30 days that a provider asks for. But we really put all of the services into that benefit plan. And then the purpose is that when a person arrives to a provider based on that biopsychosocial assessment, based on the treatment plan building, it is the provider and the person served saying, how much time do we think that you need in treatment in order to accomplish your treatment goals? So I know the old way, back when I even started here five or 6 years ago, back one of the old ways was when Access would make a referral for the higher levels of care, it would be, for short-term res, you start off with 14 days. We have really tried to move away from that. When we refer, we're referring and saying someone's appropriate for short-term res. Length of time, that's to be determined by person and provider. So let's see, individualized care. Again, treatment is planned according to the needs of each person. The unique strengths, needs, and goals of the person are critical to every stage of the decision-making process. It's important that we don't forget that a person served, they are an individual and their stories are individualized. So we really have to look at every situation, every person, and say, what is going on? And what is this person's unique needs that need to be addressed? Next, we have goals of treatment. The goal of treatment ought to be altering the course of the person's disease towards wellness and recovery. So ultimately, the goal of working through treatment is to alter where someone's headed and to have them geared towards having a recovery-based lifestyle. Next, we have interdisciplinary approach. Addiction is a complex, multidimensional condition. It requires collaboration between a variety of professionals to promote recovery. So that means medical doctors, core providers, if a person has significant mental health. It's so important that when a person comes to you, that you identify all physical and behavioral health needs and care coordinate with all other professionals treating the person. You know, on the access side of things, when we have people come in at times, I can see in our EHR that they're open with a core provider. And sometimes we'll have people who are hesitant. We'll say, hey, you know, I see you're open with Easter Seals or CNS or TTI. And, you know, can we reach out to your case manager and let them know this is that you came in, here's the treatment plan. And sometimes we have someone go, well, I don't know, let me talk to them myself. And, you know, we really try to let the person know and put their mind at ease that, you know, really what's going to serve you best in the end is a team approach. And that means everyone from your CPA to the doctor at the provider you're at, to the therapist to the provider you're at, to your case manager and therapist at your CPA. We really, all hands have to be on deck, so that way we can really make sure that we are giving you the best care possible. Broad continuum of care. So the ASAM criteria advocates a broad continuum of care to meet the diverse needs of individuals. While many areas do not have a full continuum of resources at their disposals, working with this mindset can help you offer the most individualized, person-centered care as possible and increase the possibility of more levels of care in the future. So as a PIHP, we are constantly evaluating the levels of care that we are offering within our system. There are some levels of care that we don't offer because we don't have the need come up very often. And then also as a PIHP, what we're evaluating as well is ensuring that within our network that we make sure that access to each level of care can occur timely. So that is always something that we are looking at each day. Next, we have move from treatment failure. Some have required treatment failure as a prerequisite for more intensive levels of care. This risky approach does not appropriately address addiction and may increase costs. There would be no reason to use the ASAM criteria if treatment failure were an appropriate rationale for admission. I know with for-profit health plans, I know that my last knowledge, I don't want to misspeak, but my last knowledge was that this was something that usually they look and ask for. If somebody has not ever engaged in outpatient or intensive outpatient, and they present to their healthcare provider asking for a higher level of care, such as a detox or res, they will look at it at times and say, well, you know, you've never done IOP, you've never done this or that, so why don't we try that first? ASAM says, no, we shouldn't be looking at treatment failure as a part of how we place someone. Next, we have medical necessity. The ASAM criteria defines medical necessity as necessary care for biosocial severity in all 6 of the criteria's assessment dimensions. We then have role of the physician. Physicians play vital roles in supervising and managing treatment. Their skills in diagnosis can be helpful in working with co-occurring conditions as well. And for informed consent, providing individuals with clear information enhances the working relationship, increases collaboration and shared decision-making and treatment, and is consistent with motivational engagement strategies and person choice. So we try to make it a point all the time. You know, when we have someone coming through Access, we're telling them all the levels of care that they would qualify for. If I have someone who's using opiates, then I'm making sure to look at and discuss with them medication-assisted treatment. What does that consist of? What does the medications consist of? That it is a commitment. When you look at the possibility if methadone would be the what is prescribed, then that's a commitment, and to go to the clinic every day to dose. So we try to make sure that we're not just telling someone, oh, here's the service. We're really taking the time to explain to them, here's what this means big picture. Here's the things to consider. You know, I'll have people who are kind of on the edge and they're going, well, I don't know, I really don't want to use medication-assisted treatment. I really just want to be clean and sober on my own. I don't want the use of any medications. And so we take the time to talk to them about what does that look like then? And okay, we understand what your ultimate goal is. I know big picture. I know as the professional in the field that the use of medication-assisted treatment, the studies have shown that is the best course of treatment for opiate use disorders. But again, it always goes back to what does person serve? What are they asking for? What is it that they feel is going to work for them? So when I have someone saying, I really want to do the detox res, I don't want to have to use medications for the rest of my life, I take the time to teach and educate them and let them know it doesn't necessarily mean it's the rest of your life. It could be the rest of your life you're on those medications. But at the end of the day, when they want to do the detox res, absolutely. And then I also encourage them and I tell them, while you're in treatment, take the time to ask medical questions, ask your counselor questions, ask the questions about medication-assisted treatment, because that way, should you come out of treatment, should you be maintaining your sobriety, and 2 months into it, you find that you're struggling with cravings and you're going, oh gosh, I'm at the verge of relapsing, I'm feeling jittery, I'm feeling on edge, then you know you can come back to me and we can look at medication-assisted treatment like Vivitrol, Suboxone, and you know maybe that is a way that we have to go. And I encourage the people we serve, I encourage them, you know, take the time to do the work and learn so that way you can make an informed choice about services that you receive now or in the future. All right. And then lastly, we have adolescent-specific needs. So adolescents have different treatment needs and need to be approached differently. To this end, the ASAM criteria includes adolescent-specific diagnostic and dimensional admission criteria all throughout the book. All right, with that, I will pause for a moment. And does anybody have any questions or comments over all the information we just covered? Okay, we will, not at this time. Okay, perfect. We will move on. Next slide, please. So decisional flow. Let me see. So decisional flow, it is the process one should move through when determining the appropriate types and intensity of services for an individual in order to provide individualized person-centered services. One of the concepts, Dr. Mealy, the chief editor of the ASAM criteria, one of the concepts he identifies as the key concept of the criteria is as follows. And I know it's going to sound like a lot of information, and it is. But it effectively demonstrates the proper flow of decision making. First, identify the problem a person is experiencing, then match those to the services needed. Next, decide on the appropriate intensity of those services for the person. And then finally, identify the appropriate level of care where those services will be delivered. And then throughout the entire process of doing this, you always want to make sure you're working with the person as a collaborator, collectively identifying their goals, areas of need, and services needed together. So the decision flow shown here on this slide, it is showing how a professional moves through 3 different areas with the person served. So that is intake and assessment, service planning and placement, and then level of care placement. So I just want to point out that within the decision flow, these sections, they correspond with the main 3 sections of the ASAM criteria. So if you think back to slide 5, where I talked about how to use the ASAM book and the tabs, the decisional flow matches slide 5. So the first stage of the decisional flow is intake and assessment. And that sounds exactly like what it is. That is when you are meeting with the person, you are completing their intake, you are getting their demographic information, you're getting to know them. Do they have family? Is the family supportive? Do they live alone? Do they live with others? It's when you will conduct any assessments. And look to identify, is there any history of anxiety, depression? Do we need to look at doing any assessments on there as well? So your first stage of your decisional flow, you want to do an intake and assessment, and you're looking to get to know that person, and essentially you are collecting information. The next stage is service planning and placement. And this is when a clinician should be building a case plan with goals, priorities, and services that are appropriate for the needs in each dimension. So based on my assessment with the person, their comprehensive biopsychosocial that we've completed, what goals has the person identified to work on, and what services are needed to meet those goals. So that is what we are looking at in service planning and placement. And then the level of care placement, our last part of our decisional flow. This is when you're making a decision about a recommended level of care. And to do this, you'll want to be sure to consult the dimensional and diagnostic admission criteria rules. We will go into those pieces later. But a big piece I do want to say when we get to it is if a person has not met the specific criteria that is listed out, then they do not belong in that level of care. And then we look at a lower level of care. Right. And with that, I turn it over to you, Katie.
All right, thanks, Megan. And we should be on the slide showing on my screen is decisional flow, and we should be on imminent danger and immediate need. So if we could move, it might be a few. Perfect. Thank you, Tricia. Okay, so imminent danger and immediate need, this is an essential area of assessment, and it's one that cannot be overlooked. So when we're working with people who have chronic illnesses, there's always a possibility that some of those people will pass away. And unfortunately, this is one of the sad and challenging times that can be faced. And so professionals assessing imminent danger may sometimes use subjective judgment and become lost or confused when trying to decide what constitutes imminent danger for someone. And also because it can look different for some people or for everyone. So imminent danger describes problems in many areas, such as mental health, substance use, and harm to self or others. And these three components on the slide are considered when you're using the ASAM criteria and assessing for imminent danger. So let's look at these three. So the first one, A, is a strong probability that certain behaviors, such as continued alcohol, other drug use, or addictive behavior relapse will occur. B, the likelihood that such behaviors will present a significant risk of serious adverse consequences to the individual and or others, as in reckless driving while intoxicated or neglect of a child. And C, the likelihood that such adverse events will occur in the very near future, within hours or days, rather than weeks or months. So looking at these three would be how you're determining if someone is in imminent danger. And so here's an example. If there's a pregnant woman who has a 10-year history of alcohol use, she's recently returned to substance use just this past weekend. And before that, she was sober for 4 months. She's also the primary caregiver for her other 2 young children. So this may indicate a need for services or intervention. And if you can see, that example meets all 3 of those components. Okay, so we're going to look next at the immediate need profile that the ASAM has developed and uses. This helps to objectively assess a person's imminent danger, and we'll look at, in the upcoming slides, we'll see each component for each dimension, and then we'll look through each section. Next slide, please. Okay, so this is a picture taken straight from the book. It's on page 66. It's a copy of the immediate need profile for the ASAM criteria. So we're going to go through in the next slides and look at each component, but these are all questions that can be administered. They can be done in person, they can be done by phone, but you really only need sufficient information in order to assess for immediate needs when you're completing this. But it is important for me to note and emphasize, though, that these upcoming tools are just suggestions. So it's ultimately, up to clinicians to be well educated and determine, the purpose, use, and value of the tools that they decide to use. Okay, next slide, please. Okay, so we're just going to take a look at each question. So this is for dimension 1, acute intoxication and or withdrawal potential. So is the person currently having severe, life-threatening and or similar withdrawal symptoms? Yes or no? And with these components, we aren't going to go into too much detail right now about what each dimension focuses on, because we'll be doing that later in the training. But for the purpose of these slides, we're just looking at the questions. Okay, next slide, please. And then dimension 2, which is biomedical conditions and complications. So is the person having any current severe physical health problems? It could be bleeding from the mouth or rectum in the past 24 hours, recent unstable hypertension, recent severe pain in the chest, or abdomen, head, significant problems in balance, gait, sensory, or motor abilities not related to intoxication. Yes or no? And so before we go much further with the profile 2, I want to give a reminder that with imminent danger and immediate needs assessment and with a multi-dimensional assessment, it's an ongoing process. So this wouldn't necessarily just be an upfront assessment and then, reassess in 90 days. It would be ongoing and continuous based on, the person's needs. So this could be depending on their needs and the treatment that they're needing. It could be something that's done, weekly. It could be even done daily or more often. So it just depends on their needs. But changing severity in the dimensions does determine treatment and placement upon admission, and then it guides it on a continuing basis. Okay, and then dimension 3 on the next slide, please. So we're looking here at emotional, behavioral, or cognitive conditions and complications. So for A, imminent danger of harming self or someone else, for example, suicidal ideation with intent, plan, and means to succeed, homicidal or violent ideation, impulses and uncertainty about ability to control impulses with means to act on. And then B, unable to function in activities of daily living or care for self with imminent dangerous consequences. For example, unable to bathe, care for themselves, uncontrolled intoxication with threat to imminent safety of self or others as regards, death or severe injury. Okay, and then next slide, please. And dimension 4 is readiness to change. So A, does the person appear to need alcohol or other drug treatment or recovery and or mental health treatment, but they're ambivalent or feel it's unnecessary? For example, severe addiction, but they feel, controlled use is still okay, or they're psychotic, but they blame a conspiracy. And B, has the person been coerced, mandated, or required to have assessment or treatment? Could be by mental health court, criminal justice, health or social services, work or school or family or a significant other. So here we're really looking at the person's readiness to change. And so I want to note that dimension 4 immediate needs, we're not looking at a medical emergency, but the immediate needs would be if the person is not likely to follow through or if they're likely to miss an appointment. Okay, and then dimension 5, next slide, please. So A, is the person currently under the influence and or acutely psychotic, manic, or suicidal? B, is the person likely to continue to use or have active acute symptoms in an imminently dangerous manner without immediate secure placement? And C, is the person's most troubling presenting problems that brings them for assessment dangerous to themselves or others? So then there are examples in dimensions 1, 2, and 3 about that type of behavior. Okay, and then next slide, please. So this is the 6th and final dimension, which is the recovery environment. So are there any dangerous family, significant others, living or working or school situations threatening their safety or their immediate well-being or their sobriety? For example, living with a drug dealer, physically abused by their partner or significant other, or they're homeless in freezing temperatures. So for this dimension, we're concerned with the people who need safe living today. Many people are continuing to use or relapsing or have unsupportive environments, but they still survive or live homeless. So really we're looking here at the immediate danger piece and if they need a safe living environment today. Okay, next slide, please. All right, here's the answer key for this tool. So this is also, on page 66 in the book. This lists the relevant treatment interventions based on the scoring for each dimension that we just went through. So if you take a look at each one, it shows you if you scored yes to these certain questions, then, this is what the treatment intervention is recommended to be. So it does list that all out for each one. Okay, and then before we move forward, I know this is where we were thinking we would take a break. So maybe we can take, do you want to do 10 minutes, Trisha?
Sure, that'll bring us back at 9:05.
Okay, perfect. We will see everyone back then. Thank you.
All right, well, welcome back from break. Just want to check to make sure our presenters are ready.
Hi, Trish. Yep, I'm here.
I'm
Great.
here too.
Do we want to take a moment for any questions or clarification or anything before we move forward?
Yeah, I think
Yeah.
that would be great. If everyone, you would like to unmute yourself or type any questions in the chat, let's take a moment to have available time to go over anything that we've, any questions that you might have for anything we've gone over.
Megan, Katie, I also want to add that I forgot to add in the beginning is that because we are also offering MCBAP and social work CEUs for this training, that there will be an evaluation at the end on day 2, and that everyone has to be here the whole time in order to get the CEUs.
All right, thank you. Okay, I don't see any questions right now.
All right. All right, well, we will jump back into it then. And I will say we are moving very quickly through everything today, but not to worry. You know, I will say, Katie and I, this is her and I's first time doing this. So we are able to see and tweak and find out after we do this what we need to add where for this presentation. And then we will look to offering this training probably quarterly to the provider network. So we will make changes as we go with this. So, okay, let's go to the next slide, please. Okay, so multidimensional assessment. There are 4 key components to a multidimensional assessment. The first part is the biopsychosocial. It's a multidimensional assessment that includes all relevant areas of a person's life. I want to make note that the more severe a person's condition, the more comprehensive the assessment needs to be, meaning you want to gather more information from reliable outside sources, if possible, and if you have a release of information. So again, I use examples all the time of what occurs here at Access, but that's of course what I do on the daily. So for Access, sometimes when we are screening someone, we find that they are a poor historian. The information they're giving us, we know the information, we know from our screening they are presenting with some severe symptoms, but we feel as though we're missing pieces of information for us to effectively give a good level of care recommendation. And this is when we really start to do a lot of drill down work. We have some cases that are very straightforward. We screen, we're able to identify and determine level of care, make the recommendation. Person really have to drill down on, and we work with the person to say, hey, can we talk to your case manager at the CPA that you're open at? We look within ODIN when we're able to see that there have been previous inpatient psychiatric stays, CRU stays. We're able to dig through and look at that history. There's times when someone might not be giving us a lot of information about their use, but when we really drill down and we dig through the information that we have at our fingertips, we're able to find that there's actually a lot there. And there have been times that had we not taken the time to really drill down, if we hadn't taken the time to drill down, I feel as though I can definitively say we would have made a mistake. And so I've always, you know, even though it might take us an extra 2 hours, I really try to press with staff. We have to do our due diligence. in finding out what's really the true story of what's going on. I'm sure as the providers, you guys see it all the time. That one of the screeners will reach out to you guys and say, hey, we've got an issue. This person's come back around. What can you tell us for what happened? They're saying X, but what is Y? And again, that's just us doing our due diligence. We have to fully understand. And again, there's times when we have done that and we have found out and obtained more information that has dramatically altered the course of what we would have done without that information. So next part of the multidimensional assessment is the DSM or other diagnostic criteria. So outside of ASAM level 0.5, which is early intervention, a person typically has a formal diagnosis of a substance use disorder as a requirement for admission to treatment. So that means when doing your multidimensional assessment, knowledge of the DSM is needed to identify if a substance use disorder is present. Especially when we are working with medication-assisted treatment individuals, and we are trying to decipher if it is pain management specific, all pain management specific, or if there is a substance use disorder present. One of the things, when it starts turning very gray every place, one of the things that I do first with the screener is I say, let's get the DSM. And let's first identify, is there a substance use disorder present? And from there is when we then start to look at, if we can identify that there's a substance use disorder, then we can identify and look at, okay, we should be looking at the MAT services that they are requesting. But there are times that someone might come to us, and when we do the drill down and we do the DSM and pull it out, we find that there is not a substance use disorder present. So again, that then alters and changes what we would recommend for a person. ASAM lists a definition for addiction. The short version that they give, it's helpful to know, is addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristic biological, physiological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and/or relief by substance use or other behaviors. So addiction is characterized by an inability to consistently abstain, its impairment in behavioral control, its cravings, diminished recognition of significant problems with one's behavior and interpersonal relationships, and it also is a dysfunctional emotional response. Like other chronic diseases, addiction often involves cycles of relapse and remission. So without treatment or engagement in recovery activities, addiction is progressive, and it can result in disability or premature death. Trish, can you go back one? I think it advanced. There we go. Thank you. The next part of the multidimensional assessment is risks and strengths. The ASAM criteria is concerned with a person's needs, but also their strengths. It's important to understand the way that strengths and needs can interact. And then lastly, we have dimensional interactions. And so to reiterate, a person can't be, when we talk about the dimensions, there's 6 different dimensions for the ASAM. And so a person can't be really divided into 6 parts. The dimensions overlap and they interact with each other. It's important that we recognize the ways that the dimensions interact. It's important that we recognize the ways in which the dimensions interact with and enhance our use of the ASAM criteria, which will help us refine our assessments. All right.
Megan, there is a question in the chat. Debbie was asking if the ASAM book is worth the investment.
Yes, it is 100% worth the investment. It's very important. It's very important that everyone uses the same language when treating a person. And that is really what the ASAM does. It has you speaking the same language as the other professionals in the field, and then the same language as us, the PIHP, as well, because that is what we use to make our decisions. It propels treatment. It propels length of stay. It propels the authorizations and the services that a person is receiving. So the ASAM is the #1 driving force. I can't tell you, there are times when at the access side of things, we have denied services. It does not happen often, but there are times where it does happen. And I want to make very sure, and I tell this to the screeners all the time, because I tell them, if you're going to deny a level of care that someone's requesting, and there's difference. Sometimes, everyone's very used to just the, detox and residential and MAT levels of care. They forget about the DIOP. They forget about recovery housing. They forget about all the other different levels of care that a person can receive. So sometimes with the people we serve, 9 times out of 10, we just have to educate a person and say, okay, listen, you have done treatment X amount of times. You just came out of treatment a month ago. You have relapsed 3 times. You do not meet the criteria to go back into a short-term residential, but we do think you're appropriate for a DIOP, and let's talk about what that is. And so, we have that conversation, but then there are some times when I will have somebody asking for a level of care that they are not appropriate for. And, sometimes it can be for whatever reason. They might believe it's only short-term res. I feel like I'm going to relapse, but I haven't used anything. I haven't been in jail and I haven't been in a confined environment for the last 6 months. That does not mean a person meets criteria to go back into a residential level of care. And so I always want to make sure I'm doing my due diligence as a clinician, that if I'm going to deny a level of care to someone, I want to make sure that I am correct, I am accurate, I am following the guidelines, and that also by following the guidelines, that my recommendation and the fact that I'm denying it, it's going to stand up to any other doctor or clinician who reviews the case. Because again, if we're all speaking the same language, then when I write the ASAM assessment and I identify that dimension 1 is a 0.5, dimension 2 is a 1.0, when I'm identifying and telling the story of clinically what is going on with the person, when any other professional reads it, they're going to go, yes, this makes absolute sense. So yes, the investment in the book is worth it. And again, when I first got the book, I was in the book almost daily, looking things up, making sure, am I correct? Now it's really only the complex cases that I pull it out for quite often. But it's worth it. It is needed, and you'll be happy that you made the investment with it.
I definitely agree. And I just want to add that we'll talk more tomorrow about continued stay, transfer and discharge, and the criteria and how to make those determinations. but the book also, has information about that in there. So when you are looking to request a reauthorization for someone, it'll help you figure out, what criteria are they meeting to show that that is needed, as well as other things. And like Megan mentioned, it has, a lot more detail about special populations and just different scenarios. So if you're having trouble kind of deciding how to complete an ASAM for someone or for a certain area, it'll really walk you through that and give you, a little more information and sometimes more confidence in your decision.
Yes, great information, Katie. Let's see. Any other questions in the chat? Thanks. Okay.
I don't see any. There was a question about how to purchase the book, and I do see that Derek posted a link. And other than that, I don't see it. Oh, wait, there is one more. Will we talk about what to do if a client disagrees with a level?
Yes, we will get into that a little bit. I know and actually I'll kind of touch on that a little bit right now, because I think that's probably a good place for me to hit on this with all the other pieces that I had just mentioned. So what I can say is, if I have someone who disagrees with the level of care, it really, on my end might look different than your end. On my end, what do I do? On my end, we have identified the higher levels of care that we refer to for access. So those levels of care, we have identified them as being of medical necessity. So if we deny that service and a person disagrees with it, then we send the case to an outside doctor, and we now have a new medical director, Dr. Pozios, so I'm sure our process will change. But before Dr. Pozios came on board, we have an outside doctor who reviews any denials that we make, because we have deemed detox res and medication-assisted treatment because they're deemed medical necessity, and I believe we did that because of NCQA requirements. We send any denials to an outside doctor to review it and they give a medical decision on it. One of the things that I can also say is, it depends sometimes. I know for myself, I might have someone that we screen. They come to us, they came to us because CPS said you need to be screened. We have individuals involved with court. So we have individuals who will come to us, maybe not by their own liking or wanting to. So we conduct the screening. We consult with all outside entities that we have releases for to be able to gauge what's truly going on, and then we give a recommendation. There have been times we have given the recommendation for a residential level of care, and people have disagreed with that. They did not feel as though they needed that high of a level of care. And when that happens, we tell the court, because all we say is clinically, our opinion, this is what we believe the level of care is that's appropriate for. So if somebody disagrees, we say that's okay. If you don't feel as though this is, you feel as though that's too high of a level of care, you don't wish to do that, it is your choice. Part of our core principles of how we operate at OCHN, it is that services are driven by person choice. And, with that means I tell a person, by me saying, you're appropriate for residential, that means we will authorize you up to a level 3.5 or a level 3.7. But ultimately, if you're saying you want to do an IOP, obviously you still qualify for that then. And I know for outpatient providers, you certainly see this often where you have someone in outpatient based on working with them, based on their continued use, what's going on, maybe they pick up a new charge, all of these factors. Maybe you find that, hey, Johnny, you really should be looking at going into residential. And the person says, no, I don't want to do it. And they are very resistant and don't wish to do it. At the end of the day, it's the person's choice. As the clinician, what I want to be sure I'm always doing then is saying, okay, you don't wish to do that for XYZ reasons. I make it a point to, one, talk about it in every session then. So that way, when it comes time for reauthorizations, my notes are always telling a story. My notes are telling the story that we identified that a higher level of care was more appropriate. That person does not wish to do it because of XYZ reasons, that they were offered a peer recovery coach, they were offered case management, what other services did I offer to them, and how am I then addressing their continued substance use at an outpatient level. Because ultimately, at the end of the day, you're going to have some people who say, nope, I refuse. I will not go up to a residential. I'll increase my outpatient, but I will not go up to that higher level of care. Sometimes with individuals as well, I've had this happen before. A lot of times it's about educating some people about the different levels of care. I had somebody come to me before, they specifically wanted a detox res for benzo use. And when I got to the nitty gritty of how much, how often, are you prescribed, are you buying it off the streets, are you taking anything illicitly, what it came down to was the person was being prescribed 3 milligrams of Xanax per day, had been prescribed it for about 6 years. And they were not abusing it. They were not overtaking it. They did not run out of a script. They were not buying it off the street. They were not supplement. They were taking it as prescribed for 6 years. And through talking to the person, they were very concerned about it because their parent had a history of substance use. They were very concerned that they would develop a substance use issue, and they wanted to come off of it. The person wanted to come off of it, but every time the doctor tried to titrate, they would go through withdrawals. So hence why they came to me. Well, I go through withdrawals every time I try to come off this medication. And so part of what I had to do was talk to the person at length. They weren't appropriate for a detox res. And so part of what I had to do was spend my time educating the person and explaining to them, this is what a substance use disorder looks like. You do not have that. She had been on the medication for 6 years, but doctor was trying to titrate her off in like 30 days. And so I was like, yes, you are going to have withdrawals, but that does not mean you have a substance use disorder. That means you're titrating too quickly. And I had to work to help reframe the expectations of how quick they could come off medication. Understand, you've been prescribed a medication for 6 years. You are not going to be able to go down to taking absolutely nothing over the course of 1 or 2 months. You have to be very realistic and understand, to titrate off this medication, it's probably going to be a minimum, and that's just me not with any medical background, that's me saying minimum 6 months, could very well be longer. So no, those are some of the different ways that disagreements can come up with level of care and what you can look to do with that. Another question in the chat, how do you determine whether someone needs a 14-day inpatient program versus 30 and 90? Well, I will say this, and hopefully this helps. So the term long-term residential, it's really not an ASAM term, if you will. You'll notice that when we talk about ASAM today, when we go through this training, you aren't going to hear us use the term long-term residential. And that is because we are really working to shift some of our own terminology behind the scenes. Long-term residential, it's essentially residential, it's just done in a longer time frame. So when it comes to how do you determine whether someone needs a 14-day versus a 30-day, it really depends on the person, as well as using the ASAM criteria for the continued stay review. And Katie will go over the continued stay review criteria later on. For those of you who have worked with me before, you will know I love the continued stay criteria. I will reference it all the time. It's page 303 of ASAM. The continued stay criteria is what you are looking at as a clinician to identify, does this person need to stay longer? Clinically, here is what I am looking at to identify if the person should remain in treatment services longer. On the access side of things, how do we determine whether someone needs a 14-day versus a 30-day? Again, this goes back to we don't at Access. Again, the old way was that when we would refer, it was 14 days to start. They could do up to 28. But again, when SUD made that transition and we moved from CareNet to Odin, that's when we built the benefit plans. The benefit plans can authorize up to 30 days. And how long a person does, we don't put time parameters on that, because that is determined by the person's needs, as well as clinically the treatment plan. Here's what we've identified, needs to be worked on. On the access side, when we look at having someone do a longer program for residential, one of the things that we are looking at is their past treatment history, how many times they have done residential, have they completed residentials? One of the things I'm always reminding the screeners of, they might see a high amount of treatment referrals in the system, but sometimes we have to go through and count, and we have to say, how many programs have they actually completed? And then we're also looking at where have they completed. I'm sure everyone has seen some very complex cases come through your doors. And on the back end at Access, we are always looking at where have they been successful in the past. When I have someone who's been everywhere and their case is very difficult, one, chances are my hands have been on it, because staff will bring things to me to case conference and say, there's a lot going on. Where should we be going with this? One of the things that we'll look at when the case gets very complex, one of the things that I'm looking for is where have they completed? Because yes, we've tried many things, but where have they actually completed? And because that helps give some insight and guidance on what we should do next, and how we think they will respond to treatment this go around as well. All right, let me see. How about we, let me see, we did that. Okay, let's move on to the next slide, please. Okay, so it's important that we don't lose the unique story about an individual, that we don't want a person to just become a series of forms, check mark, and boxes. Specifically, when we built SUD into Odin, one of the things that I kept in mind a lot, yes, there is some specific information that we want to be able to pull data on later. And so in order to pull the data, we have to have drop downs, radio buttons, yes or no questions. So in order for us to get that data, we have that. But then there are still also places within ODIN that they are wide open text boxes. And the reason for that is because every person is unique. I literally was having a conversation with one of the screeners the other day, and we were talking about ASAM, and they're trying to learn more, and there's someone who was recently trained new on it. And so they were asking me a lot of questions about it, and I kept, because they kept saying, as I'm sure everyone here probably does, but I don't understand. What am I missing? What am I missing? It seems like it's so abstract. And I said, it kind of is. It's not, you know, it's, a person is not going to give you information where it's check this, check that, and boom, there you go. This, now all of a sudden you get a level of care. It is the 6 dimensions that are put together that it allows what a story of a person to be told, and it's how those 6 dimensions function together, and then as well as how someone's substance use is affecting their everyday life. Those are all of the pieces that we are looking at. Next slide, please. Okay. So here we are. We're going to start going into the dimensions of ASAM. So, let's see, the 6 dimensions summarize a person's needs and defines the severity of clinical issues in each dimension. The dimensional analysis is the foundation of an individual plan of service for the person, and the treatment plan. Continuity between the assessment and plan support the clinically driven services. So again, this goes back to why the ASAM is important. When you do your ASAM, or when you do your assessment and you utilize ASAM, when you do your treatment planning and utilize ASAM, when you do your continued stay criteria and utilize ASAM, it's all going to drive the clinical supports and services and what you're asking for authorizations for the person. So hence why when submitting the initial auth for a person, or when you request a reauthorization, the ASAM dimension is a part of the authorization process because it tells a story. So let's see, dimension 1. Dimension 1, acute intoxication and or withdrawal potential. So dimension 1 assesses the person's need for withdrawal management services. If withdrawal management is necessary, then there's 5 broad levels of withdrawal management available, and we'll review those later on. What's important to find out is a person's history of use and current use patterns for this dimension. You'll want to ask what substances have been used, in what amounts, and over what period of time. So this can help you understand the withdrawal potential for the person. If the person has any previous history of withdrawal symptoms, you will always want to document that. Included in the ASAM criteria book are a number of assessments in the appendix that you can that can be used when evaluating a person's withdrawal symptoms and withdrawal risk. Next slide, please. So dimension 2. Biomedical conditions and complications. So the information you gather from this dimension assesses the person's need for physical health services. What you are also able to identify from Dimension 2 is if a person's current condition affects his or her ability to participate in or receive services. Or you'll be able to identify if there is a condition in Dimension 2 that will support a recommendation for a particular level of care. It is important to know that the information you are gathering in this dimension, it is to the extent that it is relevant for the care that you need to provide for the person. So there might be some medical issues that a lot of what we look at, we're looking to see, does someone's medical issues, would it hinder their ability to be engaged in a specific program? Is that going to have us leaning towards a specific level of care based on what they're reporting? So for example, I might have someone, we have seen this, and it doesn't happen often. We've seen people come through Access before where they're actively receiving dialysis 3 days a week, all day long. We have not had it come up yet where detox has been the issue, but residential has been what has been the request. And when we look at what the person's medical needs are, and we look at their ability to engage in a residential level of care based on their medical needs, unless they were in a hospital setting, which is a level 4.0, they wouldn't be able to engage with our providers at that level of care. And so that's when we have to look at and say, okay, we don't think medically the providers at a residential level can meet your need. They can meet your need at an outpatient level. And so this is when we might couple and talk to a person about doing a more intensive outpatient program or an outpatient with enhanced, depending on, with IOP, a lot of times it is, with IOP, a lot of times it is set days and times, and that might not work for someone. And so then it might be more, we call it enhanced. I'm doing air quotes. Enhanced really doesn't exist in an ASAM world, but what we mean is, based on a review of our entire network, that's what leads to the numbers in the benefit plan. So the benefit plan numbers of this many units over this amount of time, that's determined to have been the average amongst the entire network. So that's why those numbers are built into the benefit plan that way. But when you have a person such as this, when you have a person who is having significant medical concerns, that the IOP on set days and times aren't going to work for the person, but they need more than the standard, standard outpatient, which is usually like one group, one individual, then, some case management here and there. When they need more than that, then that is where your ASAM comes into play. And when you submit an authorization, your ASAM is going to outline those significant medical concerns, why they can't do residential, and why there is a need, why you are asking for more units than the normal. Because when you ask for more units than the normal, it will route to specialist it will route to UMUR for specialist review. And so, which is fine. There's nothing wrong with that because, again, every person is different. And so we might have built the system with the benefit plans to auto-approve based on the average, but then that's exactly why specialist review exists. So because people don't fit into that cookie cutter mold, and they do need to have the ability to go outside of what the norm is. I want to pause for a minute. I know there was a question I saw in Dimension 1. Are there more specific definitions for significant versus severe withdrawal in between minimal and moderate risk in the ASAM book? Derek, that's a fantastic question that, in all honesty, I couldn't tell you unless I go and drill down into the book. Katie, do you know offhand?
Well, I'm looking at the book right now. I saw Derek's question and I'm looking, and it does. So in each risk rating for Dimension 1, it talks about, the different description, and then it does include examples. So it, talks about, like, for example, risk rating number 1, if there's minimal risk of severe withdrawal, it gives examples of, what that would look like.
Awesome, thank you. And this is, again, everyone, as Katie and I always like to say, we know a great deal. We have used the ASAM a lot, but we are still by no means the experts. We took the ASAM training, the Train the Trainer, if you will. They call it Training to be a Champion of ASAM. We took it and with the intention of, we have a lot of knowledge between Katie and I of it, but well, when I say experts, I'm comparing myself to our trainer. That's an expert in my opinion. So there will be times, and there's times when providers ask me questions now. There's times like right now where I'm going, that's a very point blank question. I don't know offhand, because I literally would have to go look in the book. It's so important that everyone knows it's okay, because it takes a while to get comfortable and learn all the ins and outs of the book. And I think one of the things that is, hard with the ASAM, I think sometimes people, they get nervous about wanting to say, I don't fully understand this. And I cannot tell you enough, the more you are willing to say that, the more you will eventually learn, because it takes a while of use to really, truly, fully understand it. But once you ask the questions, that's when, you're able to continue to learn more and more and more on it. Alrighty. Next slide, please. All right, so Dimension 3, emotional, behavioral, and cognitive conditions and complications. Dimension 3 specifically focuses on co-occurring disorders and cognitive functioning. So how you assess Dimension 3, you should be concerned with mental health conditions that may interfere with treatment services. Mental health can be related to or not related to their substance use and may or may not impact their treatment. For adolescents, you'll want to consider behavioral conditions such as running away, defiance, and truancy. All right, next slide, please. Okay, so with Dimension 3, Dimension 3 is our co-occurring disorders. And so how you want to assess Dimension 3, you want to identify what the risk domain is. The risk domains are clear guidelines that provide structure for any level clinician to ask questions around co-occurring conditions without needing to make a diagnosis. So when it comes to Dimension 3, when you're looking at, what information is important and what level of care would I place a person in? These are the different questions you want to ask yourself. You want to look at dangerousness, the impulsivity of the person to injure himself or herself or others, as well as the risk for homicide, suicide, and other forms of self-harm. So our screening at Access, I'm sure everyone as well, when you're doing your intake screening, you're asking about current suicidal or homicidal thoughts. What I'm also looking at is when I look at, what is someone's suicidal thoughts, for some people, baseline might be that they have suicidal thoughts daily. And so whenever you have someone who's identifying suicidal or homicidal thoughts, the first thing you want to do next is be able to identify what is their means and what is their intent. One of the things that I stress to especially new clinicians, which I understand, I still joke. I was talking to someone the other day. I did my graduate school at Oakland University. So in practicum at Oakland University, you had a red folder in every single room. And it was just pushed into you so much that if someone says they're suicidal, you get the red folder. When it comes to, when somebody says they're suicidal or they have suicidal thoughts, that doesn't mean that's an immediate petition. That doesn't mean, oh, you can't be, you need immediate psychiatric care. You're looking at the severity. You are looking at their intent. You are looking at, for some people, especially with substance use, they are depressed. They feel as though they want to die. They have no plan. They have no means of carrying it out. But if you ask them how do they feel each day, they feel as though they want to die. And that's why it's important in this domain. I'm looking at it depending on how they're presenting. Is their mental health stable enough, or is it at a place where it can at least be addressed in the level of care I'm going to recommend them for. Interference with addiction or mental health recovery efforts. This domain assesses the extent to which a mental health condition will interfere with and complicate treatment. So it's always important that I'm looking at how severe is someone's mental health. There's times when we have screened on the Access side where we've deemed their mental health, they cannot appropriately engage in services until their mental health is addressed first. This is one of the reasons why, and of course, pre-pandemic, before, working remote and all of those things, pre-pandemic, this is why Access being located in the same building as Common Ground was fantastic, because there's times we would walk somebody up front. We would already have had them signed a release, and we would talk to the triage clinician for Common Ground and say, hey, this is what's going on. We're not comfortable placing them into a provider. They do need to go into a residential level of care, but their mental health, it is 100% impeding their ability to do so. If I send to a provider will petition them out. And so they get assessed by Common Ground, and they look at doing something like CRU or inpatient psych. Typically, we're telling that triage clinician exactly what we're seeing. 9 times out of 10, they're in agreement with us. And we make sure before we even take a person over to Common Ground, we tell them kind of what the game plan is. And it's rare that we have had to petition people who have been at Access. The only time we have petitioned is when we have had people whose mental health, they were unwilling to address it. They were presenting with clear delusions, clear psychosis going on, and they were not aware of it enough. They were not able to recognize it. And so we had to make the choice to say, you have to look at mental health. We don't have a choice. Social functioning. This domain assesses the extent to which the person's relationship with friends, families, and significant others, as well as their ability to fulfill their responsibilities at work or school, are affected by his or her substance use. And then ability for self-care, the extent to which emotional, behavioral, or cognitive conditions affect a person's ability to complete activities of daily living, such as grooming, fulfillment of food and shelter, especially for opiates or drugs. One of the big differences that I'm sure everyone sees just in use of culture of use, with drug use, it is an all-day event, if you will, to be able to go score drugs. And so other daily activities like grooming and food and shelter, those all get left to the wayside, because waking up, having to, be in withdrawals and trying to find enough just to starve off to put off those withdrawals for a while. And then begins the activities of, I have to seek out money. What does that entail for hours? Then I have to find who has the drugs. Then I have to find the transportation. So a lot of a person's daily things like the grooming and the food and the shelter, that can really fall to the wayside. And lastly is course of illness. This domain looks at the history of a person's illness and their response to treatment to evaluate current signs and symptoms. And the history of a person's illness is weighted against the here and now. So we always want to know someone's history, but we are also always looking at the here and now. And so, part of, what we're doing in Dimension 3. So we talk about these risks or these domains. So these are the questions you want to ask yourself. And this is where it starts to get a little complex, where it can get overwhelming, because this is only for Dimension 3 we're talking about. These are all the different questions you want to ask yourself for that dimension, for where and how would I score a person. There is, how I always like to explain it is, there's no right or wrong with how you're scoring someone, because your clinical justification, your answers to these questions, that is what is going to justify the scoring that you give someone. And so I always like to try to stress that, because it is my famous terms that I use all the time with access staff. It is gray, gray, gray. I'm always making sure to tell the screeners that just because we have a case that we are handling right now like this, do not think that if the exact same case comes along with the exact same key components, we would handle that case in the same way, because we wouldn't. And they always scratch their head and look at me, and I'm like, I understand. It's because, again, it goes back to every person is unique, and every story has unique pieces that change the course of what we recommend for treatment, how we score an ASAM, and what's identified as there being as the most needed clinical needs. Next slide. All right, so the last part of Dimension 3 to be aware of is, how does your program screen for cognitive functioning? So this is where in Dimension 3, cognitive abilities are also assessed in this dimension. So it's important that you're always looking at a person's ability to recall, recite, and explain complex information. Pre-pandemic, when we would see people face-to-face at Access, we would at times, I myself have personally done it, when we are screening someone, we only get a brief snippet. We get an hour to sit down and do our screening and ask all of our drill down questions. And then from there, sometimes more questions get raised. And so there have been times when we're trying to decipher, do we think there's significant mental health going on? Do we think there is, do we think there's limited cognitive functioning? And so there have been times where I myself have personally administered a mini mental status exam with someone because I'm trying to determine, is it a mental health need? Is there cognitive functioning that we have to look at? Because that might come into play then. That will matter with what I might recommend for treatment, but also where I might send someone for treatment. I might specifically want to choose a program that is smaller for someone who has more limited cognitive functioning. And I just say that because for a smaller program, a person won't be so overwhelmed with the size. And then as well, just the size of building, amount of people served. You might have some programs that the entire population can be upwards towards 100. Other programs, entire population might be 20 to 40. So if I have someone with some more limited cognitive functioning, I might not want to put them in that larger program. I want to keep it small. They have more eyes on them, and things can be done a little bit more slower and tailored to their needs. All right. And next slide, please. All right, this is where Katie I'll turn it over to her. And I think, Katie, should we hit on the fact of, so we've really kind of gone through things quick today. We've been emailing while we've been presenting. Katie and I are thinking we try to push through and put day 2 into day 1, and we wrap this all up today. That means that it'll be a less amount of CEUs, but considering the fact that everything was free, probably not a bad thing. You agree, Katie? We're going to try to maybe push through?
I agree. I think we can do it.
Perfect. All right, I turn it over to you.
All right, thanks, Megan. Okay, so we're now looking at dimension 4, which is readiness to change. So this really focuses on the person's readiness to change related to their substance use disorder or co-occurring conditions. And while everyone changes in different ways and at different rates, we do know that all people move through consistent stages of change. So in order to best assist people, recognizing what stage of change they may be in and then catering services to help them move to the next stage is essential. It's important to recognize that the stages are not linear, so everyone can move back and forth through different stages in a different fashion. These are some things to consider when you're doing your assessment for Dimension 4. So how aware the person is of their relationship with substance use and the negative consequences in their life, how ready, willing, or able they feel to make changes in their substance use, how in control they feel in regards to their treatment services. And these are all important factors during the assessment phase. We're going to take a further look at this model in the next slide. But this does go back to what we talked about in the question that came up earlier about what do you do if someone maybe disagrees with or doesn't want the level of care that's being recommended. So it's really meeting that person where they're at and trying to determine, how services can be tailored to meet their specific needs, how services can be individualized to meet their needs. And then, like Megan mentioned, what other supports and services can be put in place to help them in the stage of change that they're in and move into that next stage of change and, keep progressing with their treatment and recovery. Okay, next slide, please. Okay, so here we're focusing on the Transtheoretical model of behavior change. So diving into each bullet point, I'm going to give you a description for each of these. And, you may be or you're likely familiar with them. So the first bullet point is pre-contemplation. So this is when people are not yet aware that they have a problem. Contemplation would be when they begin recognizing a problem, but they're ambivalent and not sure what to do about it. They often would give both the benefits of their behaviors and the negative consequences equal weight. So they kind of just maintain status quo. Next is preparation. So this would be where individuals have decided to change and they're ready to do so. So they're, determined that they're going to change, they're ready to do it, they want to make those steps and move forward. Next is action. This would be when individuals commit to change and then they implement their plans. And then last is maintenance. So in this stage, people are practicing their new behaviors, they're practicing avoiding relapse, and then, as I said in the last slide, that they can kind of move between these stages of change and a different nonlinear pattern. So I want to have you take a moment and think about your program. So what stage of change generally do you think people are in when they arrive at treatment, in your program? Okay, and so once you've kind of thought about that and maybe have an idea of generally what stage of change they're in. So I see contemplation, preparation, action, contemplation, pre-contemplation. Okay, so now think, are the services provided at your program designed for people in that stage of change? So do the services seem to be tailored for that stage of change? Okay, sounds like it, yes. Okay, so yeah, just some food for thought. And I also want to mention that, typically everyone doesn't leave services in action or maintenance stage of change. They may, they may get to that point where, that's where they're at. They've met their treatment plan goals and they are ready for discharge or to leave treatment. But discharge may also occur when they're at any other stage of change, because discharge would be related to the resolution of their clinical issues that they came into treatment with, or, that justified that level of care. Okay, and next slide, please. Okay, so dimension 5, we're looking at relapse, continued use, or continued problem potential. Dimension 5 is really assessing a number of factors related to relapse, continued use, or the continued problem potential. And these are some things to consider. Is a person in immediate danger of continued problems or mental health conditions? Do they have an understanding of or coping skills for their condition to prevent relapse or continued use of problems? Have medications assisted in their recovery before? What are their skills in coping with withdrawal cravings or impulses? How well can they cope with negative effect without reoccurrence of addictive thinking or behavior? How severe are problems that may continue or reappear if they're not successfully engaged in treatment? How aware are they of relapse triggers and skills to control impulses related to addiction or harming themselves or others? So these are all questions you can ask when you're doing this assessment for Dimension 5. And relapse or continued use really needs to be assessed, and the treatment plan and course of care may need to be modified to address the current assessment. So relapse, then could be understood as the person's maybe not progressing with their treatment plan rather than they're not progressing with treatment. So it gives a little bit of a different view that they're, working on their treatment plan and maybe not moving forward with those goals rather than, treatment's just, they're, not being successful with treatment. I do see a question in the chat. So if someone is participating in an intake assessment, is that not action? And I would say, it could be. I think there's a lot of other factors that would come into play with that too. So it's really assessing, what are their motivations for treatment? How engaged do they want to be? Are they there because maybe they're court ordered or there's another reason that they're required to do an intake assessment? So I think you really have to assess and see what their motivations are as well. And then someone else just made a comment that motivation is really important here, which is definitely the case. Okay, and next slide, please. And then I see another comment. Stacy's an intake clinician and sometimes they're court ordered to receive services or probation is requiring it, or they're referred from a psychiatric hospital. So yeah, that's definitely true. Sometimes there are, other reasons that they're required or that they are engaging in services. So their stage of change could definitely differ from that. Okay, so this is just continuing on with Dimension 5, talking about relapse and continued use. This is just a graphic to show, relapse, continued use, or continued problem potential in the center, and then just some of the factors around it that can be considered when you're assessing for this dimension. So relapse is a treatment issue that can be assessed and treated. And some of the things that you can take into consideration, so just moving around, in these boxes, looking at the person's self-control, what are their coping skills, what's their level of impulsivity, looking at their behaviors, and also looking at their pattern of use. So what is the history of their use, as far as length of use, dependence, level of severity, and then also looking at if they've had extended periods of abstinence or have been able to reduce their use in the past, as well as other reinforcements, so positive reinforcements, negative reinforcements for their use, and reactivity to acute cues, so triggers, different situations, and stressors for them, positive or negative stressors. So really taking a look at all of those different factors to determine the level of risk for relapse for them or for continued use if they are, using. So it's been a long tradition of keeping the treatment milieu drug-free, but that's also meant that those people struggling with relapse are often not able to be as engaged in treatment. Of course, if someone's bringing in drugs to sell or they're trying to entice others to use with them, then in that situation, discharge may be looked at. But if people are struggling with either their feelings about abstinence or their skills in controlling substance use, then, they need help when relapse or continued use occurs. So now we're looking at the sixth and the final dimension. This assesses for the person's need for recovery support services and looks at their recovery environment. So assessment considerations here include, do family members, living situations, and are there transportation, childcare, housing, or employment issues that need to be clarified and addressed? So here what we need to look at for their environment is specifically, what does the supportive environment look like to them? So we want their perspective, we want to know what it's like for them. This could look different for everyone, and for me, my definition of a supportive environment could look very different than someone who's been chronically homeless. So we really need to consider the person and their unique life and story here. The information gathered in this dimension really needs to convey information in a way that captures their story, which I know Megan talked about earlier, is just making sure that we continue to focus on their unique story and not let that get lost in the process. So really, when you're doing this, think about it, find out, learn from them, learn about them. So where do they live? Who are they in the community? And what are their peer relationships like? All of this information about them matters for the ASAM, but it matters to them, and it definitely matters for their treatment. And Dimension 6 can be understood simply as shelter, but it's really more than that. It's about the whole person, their environment, and so focusing and recognizing on the broader perspective of it is what's really, at the heart of individualized treatment. Okay, I think that's all for Dimension 6. So next slide, please. And then I think this is where I turn it back over to you, Megan.
Yes, thank you, Katie. Okay, so risk assessment. So now that now that we've talked about each of the 6 dimensions, let's talk about what do I do with all of this information that I just obtained from the person. So when it comes to ASAM, those 6 dimensions, that is the information I'm looking at obtaining from a person. And so when you obtain that information, you will want to complete a risk assessment in each of the dimensions. And this is when you identify the severity of symptoms or clinical issues within each dimension. Now, literally, within my department, I don't have risk assessment ratings built in anywhere, nor does ASAM say that you have to. you can choose to, as an organization, you could choose to have your ASAM dimensions and then have a risk assessment rating next to each one. For purposes of my staff, no. Risk assessment, that is something that we are taking note of in our minds, that when we are screening a person, we are saying, okay, this is the risk assessment I would categorize someone to. It's important that I want to note risk ratings don't determine the level of care. Understanding a person's risk in each dimension is simply helping us to assist in identifying a level of care, but the risk assessment and what we assign to someone, it is not the be all end all. It is not and with the risk assessment, it is not a eureka moment. There is not a point in time where you go, oh, well, dimension 1's a 3, dimension 2's a 3. Like, there is no key. There is no, well, if I mark this many risk assessment, that means that it would go into this level of care. No, that does not exist. What the dimensions do and what assigning a risk assessment does, it goes back to telling that entire story for a person. What is truly determining the level of care is the totality of all the clinical pieces added together, which then presents a clinical summarization, which gives the story of why a level of care is appropriate. For dimension 1, just because I score someone at a 4 because they're drinking a gallon of vodka a day, that means for my dimension 1, I've scored them as a 4. I am telling myself that this person has the utmost severity. They are in imminent danger with how much alcohol they are using, that we have to look at an immediate detox treatment. Yes. But when it comes to the next pieces, like, would it be followed by a residential? Would it be followed by a DIOP? Would it be followed by outpatient? All of that just because I scored the person as a 4 with how much they're drinking, that doesn't mean all the other pieces mean someone is a 4. So for another larger issue, let's see. Look through. So for a large example, we have a person using alcohol, drinking 12 to 16 beers a day, followed by a shooter or 2. How much and how often they use, that alone cannot dictate the risk assessment I give a person. Yes, I can say this person is drinking a lot, but that information alone doesn't dictate that I give the person a risk assessment of a 4. The next pieces I want to ask the person about are their detox history, history of seizures, shakes, tremors, sweats, vomiting, diarrhea. When did you have your last drink? What is their age? Do they have complex medical issues? So let's say I got Johnny Tippy Toes. As anyone who knows me knows, I love Johnny Tippy Toes as my example. Johnny Tippy Toes, he's 32 years old. He comes to me, he reports he's drinking that 12 to 16 beers a day, sometimes a shooter or 2. Reports no previous seizures went from withdrawing, has had previously significant symptoms such as vomiting or shakes in the past. Reports current symptoms of withdrawal to be none. Reports I feel absolutely fine. Last drink was about a day, maybe 2 days ago. You know, you always get that, oh, about, day and a half ago. The risk assessment I would give the person would be somewhere around a 1 or a 2. And I wouldn't send the person to detox. Part of what I'm looking at when a person comes to me is, How much, how often are they currently using? What are their current symptoms of withdrawal that they're experiencing? As well as, do they have chronic medical conditions that could become exacerbated anywhere? Now, if I had a person who tells me they have a significant history of heart issues or high blood pressure, or they're telling me other medical issues that, I know that from withdrawing, you're going to have increased heart rate. You're going to have all these other factors that come into play. Then there's times where the conversations we have with a person are, we're not medical. Really, it's going to take a medical doctor. I get it. You're telling me you feel fine, but I'm telling you I'm not medical. I'm telling you based on everything I see, you would be appropriate. So how about this? Let's have you head to the provider. They will do a medical assessment when you get there. And if you don't need detox, great. They will put you right into a residential facility, into your residential program. Because there are some times where it's like, based by what I'm seeing, I have high concerns. My risk rating is high, but the person is presenting a little different to me. At the end of the day, I then defer to the expert, the doctor. I explain to people at times there's medical things that you cannot control. Your breathing, your heartbeats per minute, the goosebump, all of those things that go into a cow's or a sea log are things that people, that they can't control that. So I tell them, just be assessed, so that way we make sure that medically you are taken care of. So with what I'm doing, again, when I'm working with that person, I'm taking all those clinical pieces that I have gathered from my my screening, and I'm giving them a risk assessment in each category, and I'm using all of that information to come together to a final level of care determination. Next slide. So assessing severity and level of function. When assessing severity, there are always 3 H's to consider: history, here and now, and how worried now. History is important, but it never overrides the here and now. An example would be those withdrawal symptoms. Yes, they have a history, but no, there are not any current right now. Here and now always takes precedent over history. For example, you might have someone who has no history of suicide attempts, but they are currently presenting as severely depressed with suicidal thoughts and plan. You wouldn't dismiss it just because there's no history of it. When assessing for how worried now, ask yourself how worried you are about each of the areas of the person. So I'm looking at how worried am I for each of those dimensions. All right, next slide. All right, Katie, I turn it back over to you. Do we maybe want to take just a few minutes, since we are going to go all the way through? Do we want to maybe take another 10?
I think that's a good idea.
Okay, perfect. Trisha, by your clock then, are we looking at, well, my clock would put us back about 10:35. Is that about right?
Exactly.
Perfect. So we will see everyone back at 10:35 and we will finish this up.
Thank you.
All right, it's 10:35 over here, so welcome back, everyone. Are presenters ready?
Yes, I am. Thanks, Tricia. Okay, so we're going to go ahead and get started, and now we're going to dive into withdrawal management. So we're going to talk more about this in the upcoming slides. And when substance use has progressed to the point of physical dependence, withdrawal management then becomes the first priority in treatment planning. So this graphic on the slide is showing the withdrawal management levels of care, and they're moving from left to right, showing the scale as more stable on the far left, and then moving into a more compromised state as we move to the far right. So there's a major difference between withdrawal management for adolescents and then withdrawal management for adults. So basically, adolescents do not have unbundled withdrawal management services. If there's an adolescent suffering from severe withdrawal, this is severe enough a condition to warrant treatment within their existing treatment milieu. And here's another shift in terminology that we've seen. So previously, withdrawal management was known as detoxification services, but now it's referred to as withdrawal management. And this new terminology does better represent the services being offered. Withdrawal management attends to the full range of biopsychosocial needs that people are experiencing. So in the coming slides, we're going to look at the different withdrawal management levels of care. And next slide, please. So we're going to start with level 1, which is ambulatory withdrawal management without extended on-site monitoring. So I'm going to talk about each different level of withdrawal management and then, what's included, what that entails, and then some of the differences. I'll give you an example. So level 1 is an organized outpatient service, which may be delivered in an office setting, could be a healthcare or addiction treatment facility, or it could even be in a person's home by clinicians who provide medically supervised evaluation, withdrawal management, and referral services according to a predetermined schedule. So the people or staff providing these services would be physicians, nurses, physician assistants, nurse practitioners, and then counselors, psychologists, social workers. They would also be involved in supporting people while they're receiving these services. So these are provided in a regularly scheduled session, and they should be delivered under a defined set of policies and procedures and medical protocols. So an example of level 1 would be a physician's office or a home healthcare agency helping someone through their withdrawal management. Okay, next slide, please. And then level 2 is ambulatory withdrawal management with extended on-site management. So this would also be an organized outpatient service, which may also be delivered in an office setting, healthcare or addiction treatment facility, or again, it could be in a person's home by trained clinicians. These are also provided in regularly scheduled sessions. In this level of care, it's essential that there's availability of appropriate credentialed and licensed medical staff who would monitor the person over a period of several hours each day they're in service. So again, same type of staff, physicians, nurses, PAs, nurse practitioners, counselors, psychologists, and social workers. So an example of this could be a day hospital. And as you can see, the severity of need increased from level 1 to level 2, and that they're monitored over a period of several hours each day of service rather than, just scheduled appointments. So ambulatory withdrawal management applies to people experiencing withdrawal from opioids. In contrast to withdrawal from alcohol or sedatives, withdrawal from opioids does not itself present the imminent danger of death. However, if there's co-occurring medical, psychiatric, environmental situations, those all have to be assessed in making a determination for the level of withdrawal management that's needed. So those are definitely factors when determining this, and those may, change the withdrawal management level that someone needs. But, if those things are minor or not present, then this level of withdrawal management could be appropriate for opioid withdrawal. So here's another important and essential tidbit. So using clinical judgment when assessing a person going through withdrawal for opioid use is essential. So you have to consider other things too, like is the person likely to use again overnight? Can they not be stabilized by the end of each day when they're in this program being monitored? And if not, then ambulatory outpatient may not be the best course. Okay, next slide, please. Okay, and so now we're going to talk about level 3, which is residential or inpatient withdrawal management. And there's 2 different types. So there's level 3.2 and then there's level 3.7. So level 3.2 would be delivered by, again, by appropriately trained staff who provide 24-hour supervision, observation, and support for people who are intoxicated or experiencing withdrawal. Clinically managed residential is characterized by its emphasis on peer and social support. So this level does provide care for people whose intoxication or withdrawal signs and symptoms are sufficiently severe enough to require 24-hour structure and support. It's designed to safely assist these people through withdrawal without the need for on-site access to medical or nursing professionals. So that's kind of, that's one of the main differences between level 2 and level 3.7, and we'll talk about that. But for level 3.2, they may still need 24 hours a day monitoring, but medical and nursing professionals may not be available like on site 24 hours a day, so they're not the ones monitoring, but they would still be available for consultation or for anything else that's needed. They're available 24 hours a day. So they may not be physically there, but they're still available. So a lot of the support that they're getting, again, in level 3.2 is on, as peer, social, and other types of supports. So an example of this would be a social setting withdrawal management. And I see a question in the chat. Are we supposed to say that we are back? And Trisha, I will let you answer that. I'm not sure if that's required.
That's not required. I'm able to see when I download the attendance list, so no worries.
Perfect. Okay, thank you. Okay, so level 3.7 is also an organized service delivered by medical and nursing professionals who provide 24-hour medically supervised evaluation and withdrawal management in a permanent facility with inpatient beds. So that's, the main difference, like I said, is the medical and nursing professionals are there, they're evaluating, they're monitoring, they're providing a lot of that care. Services are defined under a set of physician-approved policies and physician-monitored procedures and protocols. So this level is for people whose withdrawal symptoms are sufficiently severe enough to require 24-hour inpatient care. And let's see, and then at this point, the full resources of an acute care general hospital or like a medically managed intensive inpatient treatment program aren't necessary. So again, the staff that would work this type of program would be physicians, PAs, clinicians, counselors, social workers, psychologists, and an example of this would be a freestanding withdrawal management center. Okay, next slide, please. Okay, and then the last level, which is level 4 of withdrawal management, is medically managed intensive inpatient withdrawal management. So level 4 is an organized service delivered by medical and nursing professionals who provide 24-hour medically directed evaluation and withdrawal management in an acute care inpatient setting. So these would also be, services would also be delivered under physician approved policy, procedures and protocols. And this would be when somebody's withdrawal signs and symptoms are sufficiently severe enough to require medical and nursing services 24 hours a day. So an example of this would be acute care or psychiatric inpatient hospitalization. So with any withdrawal situation, make sure to evaluate based on all 6 dimensions of the criteria and then how they interact with each other. So Megan talked about that earlier, how all 6 of them, intertwine and how they all interact with each other. It does play a role in determining placement and level of care. All right, I do see a question. Has 3.2 taken the place of 3.1 to 3.5, low intensity through medium to high intensity? And
so that's a great question, Derek. And I think what you're referring to is the residential levels of care. So residential levels of care, you have your 3.1 to 3.7. Withdrawal management has its own set. It's level 1, level 2, level 3, level 4 WM. So it's level 1 WM, level 2 WM, level 3 WM, and then within the level 3 you have a 3.2 or a 3.7 WM, and then level 4. So withdrawal management, it has its own completely separate headings, if you will.
Thank you, Megan.
Yep.
Okay, and I think I'm turning it over to you at this point.
Yes, ma'am. So, okay, next slide, please. Yes, and Derek, I'm so glad that you asked that question, because let me tell you, it took up until I was building SUD into Odin, when we were creating SUD for Odin. It literally, I was always so confused over, what do you mean 3 WM, 4 WM? How's that different from dimension 1? And so it finally took that for me to drill down and understand, oh, wait a second. Withdrawal management has its own continuum. It has its own set of characteristics that we are looking at that are different from what you are seeing on your screen right now for levels of care. Stacy, we will get to that. We will get to your question. I thought about you guys when I was writing in a very specific piece about recovery housing that'll be coming up. So there are 5 broad levels of care for the ASAM criteria shown here. We're going to do a brief overview of each. It is important. I want to point out that the book lays out the levels of care in this line, this continuum that you see. They do it to make it easier to understand. But people will jump in and out of the system all over the place. It is not a straight line that people must progress through, whether it's going up or going down. I'm sure everybody knows, we might have someone who enters up at a 3.5 level of care. They do 30 days of residential. Maybe they drop down to a level 1 to outpatient services. So as you can see, they have bypassed a 2.1 and they've gone straight to a 1. Say they're an outpatient, they've been doing outpatient for 6 months, a year. Say COVID hits and they have relapsed, and it's not a daily relapse. It's of course a significant relapse. They had clean time. They come to Access. They say, I'm looking to maybe go residential. We screen, we say, well, we're not thinking, that high intensity of services is needed. We're looking at more like an IOP or maybe a DIOP. So there's not a straight line. So say that person's in the IOP, and after they complete that, they say, you know what, this is enough therapy for me, I'm done. And then we don't hear from them for 8 months. And then all of a sudden they pop back up at outpatient services because they have used once or twice. So they begin again at outpatient services. So a person can enter the system anywhere. They can move around the system. It is not a straight line by any means that a person must progress through. Also, one of the things that I want to point out, one of the things that I want to point out is what I'm going to go over. I'm going to go over some basics about the level of care. I'm going to talk about what makes an early intervention program, what makes outpatient services, what does that look like. But one of the things that I'm not going to go over, because it would just be time consuming and it's in the book, it is the diagnostic admission criteria. And that admission criteria, that is when you get into the, like it spells out, for dimension 1. this must be met. Dimension 2, the person's status in Dimension 2 is characterized by one of the following, A or B. And all of that, it is very clearly defined in the book. There's really not a whole lot of questions. That's probably one of the easiest things that I understood from the book from the very beginning is that diagnostic admission criteria. It spells out what must be present in every dimension for someone to meet the admission criteria for each level of care. And so say I'm going through and the person doesn't meet all of the pieces of 3.5, say I get to dimension 3 and for I'm looking at 3.5, I'm doing the intake, I get to dimension 3 and the person is not meeting any of those criteria, then that tells me, oh, this level of care is too high. So a person must meet all of the diagnostic admission criteria in each dimension that is listed for each of the levels of care. It's important I point that out as well because there is a difference in the book for what is listed for the admission diagnostic criteria and the continued stay review or the transfer criteria. Those are two completely separate characteristics that you are looking at. So when you have someone who's engaged in MAT services, for example, they've already gone through their MAT intake, they have been engaged in services for 6 months, you are not looking at the admission and diagnostic criteria for residential if you're thinking they need a higher level of care. That's not the criteria you need to be looking at. You need to be looking at the transfer criteria. Katie will go into that. Her and I knew coming into this that would be a big one that we wanted to make sure to hit on when you're asking for continued stay in services, as well as if you have someone in MAT services and you think that they should go into a higher level of care like residential coupled with the MAT, what criteria is being looked at? That is page 303 of ASAM, which is again different than the admission criteria for each level of care. So, okay, let me get myself reorganized. So we will move on. We will start going over our levels of care. Next slide, please. So early intervention services, this level is appropriate for individuals who do not meet the DSM-5 criteria for a substance use disorder. Sometimes clinicians will place a person in this level of care because they're low risk. Or early intervention services, these are more of the cookie cutter programs that are created to meet a specific need. You might have like for those who received a DUI first offense, it might be that they go through a 6-week series of a 6-week series of psychoeducational materials. So that's, you know, what early intervention looks like. It is SBIRT, screening, brief intervention, and referral to treatment is considered. This is done on our community corrections side. Quite often, Lindsay is my screener over, she's embedded at corrections, she does SBIRT. What you are looking at for someone who's in early intervention, certainly if you are 5, 6, 7 sessions in and you start to obtain more information about a person, you might go, whoa, initially we thought there wasn't a substance use disorder. Now there is. Okay, now we just flip it and we are able to give them a DSM-5 diagnosis and bump them up a level to outpatient services. Let's see. In terms of the access side, how we end up using this quite often is when we have individuals coming through requesting MAT services, and we are looking to identify, is it substance abuse or is it pain management? And when we identify that it is pain management, when there is not a substance use disorder present, the recommendation we do give for a person is early intervention services, because it's important that, okay, yes, right now what you were looking for was MAT for pain management needs. That's not what we do. If pain management is present with a substance use disorder, that's different. But when it's all pain management with no substance use disorder, we always ensure that we are still looking at the overall needs of what does a person need? How can we best service them? And one of those things that we offer, our recommendation for services, is early intervention. Then we want to make sure that they understand and they can engage in some basic psychoeducational courses to understand that they're at risk for substance-related or addictive behavior because they're taking a prescribed medication. So that's how we utilize that level of care quite often on the access side. Next slide, please. All right, level one. Level one is outpatient services. Level one is also referred to as continuing care. That is a term that you will hear most often about level one. Level one is often great for individuals with high severity in dimensions 4 and 6, and who have a safe living environment. Level one services are delivered in a wide variety of settings. They're tailored to each person's level of clinical severity and function, and they're designed to help the person achieve changes in their substance use or addictive behaviors. Treatment addresses major lifestyle, attitudinal, or behavioral issues to increase a person's ability to cope with major life tasks without the use of substances. So level one services, they're appropriate in several different situations. Again, you might have a person who begins receiving substance use services in a level one program. Or you might have a person who was receiving residential or IOP, and they are coming into a level one in that manner. So you can have someone coming to a level one who's been exposed to significant treatment already, or it might be the first time that they've ever been exposed to treatment. Level one services consists of no more than 9 hours a week of services, typically for adults, and no more than 6 hours of services per week for adolescents. That means services, again, they're not one size fits all, and there's always wiggle room. And you're able to look at each individual person and identify what their exact needs are and what clinical services are needed to meet their needs. Let's see. Each outpatient program should be able to address mental health and be co-occurring capable or be co-occurring enhanced. So each program should be able to address a person's mental health in-house with a doctor who's properly credentialed, or have the ability or have a community partner that you have partnered with who is addressing their mental health. So for example, the CPAs. The CPAs might be addressing a person's mental health, or maybe you have a person come to you. They have no history of being treated for mental health. As the provider, you identify, man, we're seeing some significant needs. Then the next step you'll want to do is identify, does their mental health meet a need where it can be addressed at a basic outpatient level, or do we feel as though the person meets the need for CMH level of care services. Because certainly if it's at a basic outpatient level, again, depending on your ability as an outpatient provider, you might be able to address that in-house. For people with more significant mental health needs, you might go, let's get you connected with a core provider. Let's call up Access. Let's have a screening done for you for mental health. And there we go. Now, Access, my department, we've gotten them connected to a CPA that will directly address their mental health. They'll have a psychiatrist, they'll have a case manager, a therapist there. And as the outpatient SUD provider, you can care coordinate with that CPA. Next slide, please. All right, so level 2.1, intensive outpatient services. Intensive outpatient services consists of 9 to 19 hours per week for adults and 6 to 19 hours per week for adolescents. A person in this level of care, a snapshot of what this person might look like in Dimension 1 is detox is manageable for Dimension 1. Dimension 2, biomedical conditions, they're not interfering with treatment. It could be someone who does have medical conditions. They may or may not be seeing a PCP for anything. But the bottom line is they're biomedical conditions. They can be handled at an outpatient level. There's a high likelihood for relapse, or the person, there's a high likelihood of relapse for the person if they are not provided with close outpatient monitoring and structured therapeutic services. They might not be aware of their triggers, or they may have difficulty coping with or implementing their coping skills in daily life. One of the things that, you know, through the front door of Access, obviously, we certainly have a high amount of people who come through, and again, they just know the basic for levels of care. So I need detox res. And, you know, part of what I've worked with on talking to the screeners about and talking to the person served about, part of what we try to drill down on is how many times have we been to treatment? What have we learned in treatment? Whenever I am working with someone who has had relapses, or the questions built into our screening, what's your longest period of clean time? That question is there for a very specific reason. And part of that is I want to identify, has the person been able to maintain sobriety at any level? And if they have, then I always ask the person and follow up with, do you know what led to your relapse? Because that's a big question, and that's helping me to also identify a level of care. I might have some people who tell me, yep, I stopped going to meetings. I thought I could do it without it. You know, that tells me we're at a place of thinking problems still. I might have some people who be like, I have no idea. I have other people who have never had long periods of sobriety. They always, you know, when I ask them, they're like literally maybe 2 weeks to 30 days tops over the course of 6 years. And, you know, I get out of treatment, I try for a week or two, and then it just all falls apart. Well, that person right there, I'm able to see that it's coping skills and how to they are not done learning what coping skills they need to learn. You know, residential is a place where I like to say, you know, residential is where you are learning what are my triggers, and you're also starting to learn what are coping skills for each trigger. Then when you look at, you know, doing a longer term residential, you know, for more than 30 days, you know, if it's a more 60 or 90 days through our through Turning Point, or if a person's looking at DIOP, part of what we look at with those is, you know, those are the programs where people can really begin to implement the coping skills they've learned. They are able to, like DIOP, we have Personalized Nursing, Lighthouse, and Turning Point that provide DIOP services. Those are services where people are able to be out in the community more. It is not such a confined environment like residential, where you're in-house there 24 hours a day. And so part of what a person is learning how to do, they're taking the skills that they are learning in their groups each day, and they are actually going into the world, and they are actually beginning to implement those newly learned behaviors. So that's a lot of what we're looking at on our end with past treatments that people have done, and where do we think a person is at in terms of what they need to work on. Even though on the access side, even though we are not the ones providing the services, I'm always asking the person, what do you think it is you need to work on? Because I want to gauge what is their level of insight, which at the end of the day, it all goes back to helping me determine a level of care placement for the person. A person who may qualify for 2.1 intensive outpatient services, maybe a person who is in outpatient level of care and has had continued relapses and needs more clinical supports each week to assist the person in identifying signs and symptoms and coping skills. It's important for me to also note that if a person is in outpatient or intensive outpatient and say they use or they relapse or they have multiple relapses, that doesn't mean that they automatically get referred to a higher level of care. So there might be times where whether it's someone's in recovery housing, whether someone's in DIOP, just because they go out of house for the day and they relapse once, that doesn't mean, oh, you relapsed once, you should be going up to a residential level of care. And that's not to say, though, they might not. And then again, this is where it always goes so gray, where my staff scratches their head and goes, what? Because again, with one person, they might relapse one time and we might put them in residential, and for another person, they relapse one time and we say they should continue on in the level of care they're in. And that all has to do, again, with all the characteristics, it's the totality of everything going on. You might have that person who relapsed one time who might have a mental health diagnosis of paranoid schizophrenia. They might have come off of their psych medications. They are actively hearing voices. They are not suicidal or homicidal, where it would lead to an inpatient psychiatric stay being needed, but they are someone whose mental health is now going to interfere with their ability to work an outpatient program effectively. Whereas you might have another person whose their mental health, it's not significant. Maybe it's a little mild depression or anxiety. They relapsed one time. They got caught on the drug screen coming back to the program. They're asked about it. Hey, you know, your drug screen was dirty. Yeah, dude, I know. I got angry. I couldn't find a job while I was out job searching, and I ran into a friend and he gave me a joint and I took 3 hits and it was stupid and I shouldn't have done it. That person, they didn't implement their coping skills that day. That doesn't mean they would go back into a residential. They have insight as to what's going on. So that's why I say every case, just because you look at some of the straightforward facts, like, oh, they relapsed, now we drill down and look at all the individualized pieces. And that's going to determine our level of care. We have this conversation with probation and parole agents all the time. That really, with MDOC coming up under our care last year when we took over the contract, one of the things, thanks, Stacy, I know, right? One of the things that we've really tried to hit on with MDOC is Telling them just because a person relapses once, just because they've relapsed 2 or 3 times, that doesn't, when it's over the course of like 2 or 3 weeks, that doesn't mean we just automatically put them into a higher level of care. We are looking at insight. We are looking at what's going on. We are looking at their job. And the fact that there's times when, yeah, I thought someone has needed to go into a residential level of care, but their job was not being flexible. And if they went into a residential level of care, they were going to lose their job. And if they lost their job, that meant they were going to lose their house, be unable to pay bills. They were going to be in a hell of a bigger pickle than they were right now with the fact that they had used cocaine 3 times. And so there have been times where, yeah, let's go to outpatient or intensive outpatient, and let's start there. Because certainly that gets factored in as well. You know, what does, you know, the person's work look like? What is their motivation and willingness to engage in services? All right, next slide. All right, so partial hospitalization. Partial hospitalization at an SUD level, we do not have this level of care. For example, what this type of person would look like is biomedical conditions do not interfere with treatment, but may distract from recovery efforts. Examples of this would be unstable hypertension or chronic back pain. Problems in Dimension 3 are not necessary for admission to a Level 2-5. And any Dimension 3 problem present can be dealt with in a co-occurring capable or enhanced program. The person, this is where it's at, the person may live in an environment that is not supportive of recovery. But it's not actively opposing it, but is not, you know, they're not opposing it, not sabotaging it, but they're not helping it. We know sometimes that's the case in families. As we all know, when we've worked with families at times, families will tell the loved one, you are the one who is sick, get better. And I always explain to family when they come with the person to access, Mom, this is a family issue. This is not just that Johnny has to change. The family has to change. Partial hospitalization, it's also known as day treatment. Generally consists of 20 or more hours of clinically intensive programming per week. There is direct access to psychiatric, medical, and laboratory services. For adolescents, day treatment usually occurs during the day, and educational components are built into the program. So if you were to do partial hospitalization, you would either heavily coordinate with school systems to ensure all of the kiddos' educational needs are being met. All right, next slide. All right, now for our level 3. So there is multiple levels. There's multiple level 3s, which is our different levels of residential services. So I want to say this as well, I probably should have started with this, but when it comes to everyone's program, your program that you work for, you have all received an ASAM designation from the state about what ASAM level your program is. And so that is not determined by us here at OCHN. That is the state who takes a look at, they look at your program components, they look at your staffing, they look at the totality of everything. They use the ASAM. That is what they are using to identify what ASAM level of care are you able to be designated as. I think it was Stacy who had asked earlier about recovery housing. From a technical standpoint, recovery housing, it's not an ASAM level. Recovery housing, it is your standalone, it is recovery housing. Outpatient is where the ASAM comes into play. I've referenced the DIOP, which is the domiciliary intensive outpatient, or there's also DOP within our system, domiciliary outpatient. DIOP, the state has designated, so within our network, we have 2 programs that are DIOP providers. That's Personalized Nursing Lighthouse and Turning Point. The state has designated each of their programs with a different ASAM level. PNLH is a 2.1, and I believe, and I have it on my cheat sheet. When I do screenings, I have to know it because I have to mark the benefit plans. So I have it on a cheat sheet. I believe Turning Point's DIOP is a 3.3. So the state has designated them as different based on the components that are offered. So just good information to know that if you're ever wondering what are we designated as, your program manager, director, they should know. They report to Sherry what they've been designated as, because on the back end, that's what is used for authorization purposes for the benefit plan, is the ASAM level you're designated as. Anyways, okay, so level 3.1, it's not intended to describe or include sober houses, boarding houses, or group home where treatment services are not provided. So level 3.1 has 2 components of it: clinical services and recovery residence, clinical services and recovery residence services. In the ASAM book, they refer to it as recovery residence, halfway house, group home, or other supportive living environment with 24-hour staff on site and close integration of clinical services. So this, again, it's the state who's designating, and I think probably the big difference in a 3.1 versus a recovery house, you might have for a recovery house a house manager and things like that, but I think what the state means to be classified as a 3.1 for a recovery residence, that means that there is staff who lives on site. And so that is where that difference lies. Next slide, please. All right, so level 3.3, it's our clinically managed population specific high intensity. So, you know, for me to point out, you know, 3.3, it's not a step down service from a 3.5. It's a standalone level of care that is population specific high intensity. This level of care is for individuals who are better treated at a slower pace than traditional treatment levels. I want to point out adolescents aren't included in this level at all. So adolescents do not fall into this category. In ASAM, there's not a little breakout box for them. This is because adolescents are still developing, and because their substance use history is often much shorter. It is more difficult to identify persons who would require this type of slower programming. So that's why they're not included. All right, next slide. Okay, so a level 3.5. So most of our residential providers, they fall into either a level 3.5 or a level 3.7. So the hallmark of a level 3.5 program is the treatment community as a therapeutic agent. Level 3.5 assists individuals whose addiction is currently so out of control that they need a 24-hour supportive treatment environment to initiate or continue a recovery process that has failed to progress. Their multidimensional needs are so severe that they cannot safely be treated in a less intensive level of care. The goals of treatment in this program is to promote abstinence from substance use, address other addictive and antisocial behaviors, and affect change in the person's lifestyle, attitudes, and values. People may have serious mental health conditions or chronic mental health conditions. In a 3.5, it could be someone with schizophrenia, bipolar, major depression. Also, people with personality disorders can be treated at a level 3.5. Borderline personality, narcissistic, antisocial personality. These individuals who receive the level 3.5 services, they've never developed adequate coping skills. They might have a history of physical, sexual, or emotional trauma, poor social skills, inadequate anger management skills, extreme impulsivity, emotional immaturity. Their chronic use has led to impaired judgment, leaving them vulnerable to relapse. This might be the person who has attempted to cut down or stop using on their own in the past. So, you know, I mean, if you ever spent time working with someone, you know, you'll be talking to someone and they'll be like, yep, they'll wake up after a huge bender and be like, okay, I got to cut down. That's too much. I got to stop using. And I feel so sick. My gosh, I can't even look at another drug or drink. So I'm not using tonight. Well, what happens is a person then starts to feel better. Then by mid-afternoon, they're going, well, you know, I mean, I could go out tonight with Bob and have just one. And again, that goes back to people's impaired judgment. They woke up knowing, I shouldn't, this was too much, I've got to stop. They're approaching the day with a clear mind of saying, I cannot engage in this anymore. I'm an alcoholic or I'm an addict. But their judgment is so impaired by mid-afternoon, they start feeling better. And that's when the distorted thinking comes into play. And they start telling themselves, you know, I mean, I can have just one, you know. And so really the person who needs the 3.5 or 3.7, it's the person who can't stop that behavior on their own. They've tried to cut down. They've woken up and said, I'm going to stop using. But by nighttime, I feel better. And I tell myself, oh, I'm only going to have a couple drinks tonight, but a fifth later, there you go. Next slide. All right, so a level 3.7, all of the components are the same as a 3.5. The only difference is the level 3.7, it's appropriate for a person whose subacute biomedical and emotional and behavioral or cognitive problems are so severe that they require inpatient treatment, but do not need the full resources of an acute care hospital. So in a 3.7 program, typically there is registered nurses who are on staff, whereas a 3.5 program, they might utilize EMTs. So a lot of the difference between a 3.5 and a 3.7, it comes down to the type of staffing that is there, as well as then, you know, I place the person, the difference of why I place someone into a 3.5 or 3.7 is because they need a higher nursing care. So sometimes those who have a lot higher of medical needs or higher of mental health needs coupled with their substance use is when I look more to a 3.7 program. And next slide. And then lastly, we have the level 4 for residential. It's our medically managed intensive inpatient services. Again, this is a level of care we don't have in Oakland County. It is not often we come across someone who needs that high of level of care that are so severe, they require primary medical and nursing care. Typically, when you have someone who has that high of a need, they go to the hospital. They are being seen first for the medical issues because that is the predominant issue. And typically those are those individuals who can have kidney issues, liver issues, need the dialysis. So every once in a while we do come across those extreme cases where we're going, we do have something that's up there, but when that does occur, One of the things we do on our end, this is when we loop in our nurse case managers for complex case management. Individuals who are open with a CPA, the nurse case managers, they are staffed by us at OCHN. And so we make an internal referral over to our nurse case managers, which is super helpful. I had somebody once who I had to refer over to the nurse case manager, and because his medical needs were so high, he was specifically asking for recovery housing. He specifically was asking for recovery housing, but the issue was he could not stay out of a hospital long enough. He, when we got hands out of him, he was coming out of the hospital, and through doing the screening, what we had found out was for the last 2 months straight, he had, within 2 to 3 days, he would go right back into a hospital. And because of the medical issues going on. And so we immediately looped in our nurse case manager, who was then able to communicate with the hospital with us, with his Medicaid health plan, and really talk about what his needs were and what could be done. Because at the end of the day, we were saying, yes, he's appropriate to go into a residential, but medically, he is not stable enough. He cannot stay out of a hospital long enough. And so what ended up coming out of all the conversations was our nurse case manager was able to speak with the doctors and the nurses at the hospital to talk about nursing home care placement for his needs to be met in that manner first. Because the medical needs would become so exacerbated at home without someone overseeing his medical care, that with nursing home placement, he could have assisted care in that manner. And if he maintained stability, we could then look at recovery housing. Next slide. All right, and then opioid treatment services. So this is an umbrella term that encompasses a variety of pharmacological and non-pharmacological treatment modalities. This specific term is intended to offer a broad understanding of opioid treatments and to include all medications used for opioid use disorders. As well as the psychosocial services that are offered concurrently with the medications. With the opioid treatment services, the medication piece, it's one part of MAT services is what we call it, but it is not the standalone treatment. The studies show that for best success, you have to have your MAT medication coupled with therapeutic services. A lot of times when we see people on the access side of things and we find that they're just open with a private doctor being prescribed a medication, we do encourage them to come into our system of MAT medications because it encompasses not just the MAT medication, but the therapeutic services all under one roof from one provider. And that therapeutic piece is what we end up seeing missing quite a bit at times. Let's see. So an area that I want to define for everyone, 2 terms that you might hear is opioid treatment programs, also known as OTPs, and office-based opioid treatment, which is known as an OBOT. So OTPs are heavily regulated by federal agencies and involve the direct administration of medication on a daily basis. That's when you have take-home supplies and dispensing at the windows. This is our methadone maintenance treatment. So our methadone maintenance programs, they're very much what's considered by the federal government. They are what are called OTPs. Now, OBOTs, which are the office-based opioid treatment, these are physicians in private practices or within the public sector who are authorized to prescribe outpatient supplies of medications. So what that means is physicians can apply to be a prescribing physician. They prescribe under a waiver to be allowed to specifically prescribe for the use of opioid use disorders. So under the waiver, a physician takes an 8-hour training course in order to receive the waiver to prescribe. And the first year they have a limit of how many people they can prescribe to. It's usually about no more than 30. And then after the first year, the doctor can make a request to the DEA to prescribe up to, I think, about 100. And then people can come on and off the list at all times. So the OBOTs are required to keep meticulous records of who's prescribing when, what is being prescribed, and when someone is discharged and no longer a person receiving services from that OBOT, another person can be put in their place. So that number of 100 from a doctor, it can always be kept up at 100. So big picture wise, just to do a brief recap on the ASAM pieces, the ASAM levels of care we've discussed, the dimensions that we have discussed. Really, it's all of this information that you take. It is what you know about each level of care, what services are provided in each one. It's in doing your assessment and screening with an individual. You're identifying key pertinent information in each dimension of the ASAM. Your dimension 3, you are identifying what risk assessment you would give a person. You are taking all of these, I like to call it like 8 different pieces of information, and that is everything that you are taking and putting together to tell the clinical story as to why you're recommending the level of care that you are recommending. It's important that I also say that, it's okay that when you are identifying a level of care, because I've come across this before, when you're marking your level of care for each dimension, just because 3.5 residential is what the person's receiving, that doesn't mean every dimension gets marked at a 3.5. Dimension 1 is withdrawal potential. Well, person's drug choice is cocaine. They're uncomfortable, they're agitated, but do they have significant withdrawals? My assessment's risk, I'm going to put them down at about a 1. And really, in terms of withdrawal from cocaine, they're where I'd mark them on the ASAM, I'm going to mark them at a level 1.0. They could effectively handle their withdrawal symptoms at an outpatient level of care. But then we look at dimension 3. The person has a diagnosis of bipolar disorder. They are not currently on medications. They report history of multiple suicide attempts. So, when I'm looking at what level of care I'm going to mark and give for that dimension 3, yeah, I might give that a 3.5, or it could be a 2.1. It's okay that your dimensions are not all a 3.5. You can have a 1.0, you can have a 2.1, you can have a 3.5, you can have a 3.5. It's your ASAM dimensions, it's going to match exactly what is going on with the person. All right. And with that, Katie, I turn it back over to you to finish us up for the day.
All right, thanks, Megan. Next slide.
Oh, Katie, if I could stop you real quick. I'm having a hard time hearing you. I don't know if anybody else is.
Is that any better?
Yes, much better.
Okay.
Here we go.
Okay, thank you for letting me know. I think it was my headset. Okay, so if you could go to the next slide, please, Tricia. And we are looking at treatment planning now. So the treatment plan should reflect the continuity between the clinical rationale in each dimension that supported the admission, but also the services being provided. So it's also critical to understand that the treatment plan is a process. And we talked about earlier, it should be updated and modified over the course of care with a person's progress or lack of progress while they're in treatment. So the treatment plan flows out of completing a thorough biopsychosocial assessment. So here you're identifying the clinical needs in each dimension, identifying the services that they need to meet those needs, and then deciding on a level of care to provide those services. So when you're developing the treatment plan, the more accurate and concise and individualized it can be on the front end, the simpler and easier it is to develop the treatment plan and then assess treatment as the person goes throughout treatment. So the treatment plan is really the foundation for individualizing treatment for the person. And next slide, please. Okay, and so this just came straight from the book. So on page 110 in the ASAM criteria book, it talks about the treatment review timeline. So it gives, ideas or suggestions for different levels of care, how often the person's needs should be assessed and the treatment plan should be updated. So in outpatient settings, progress should be formally assessed about every 6 sessions. For acute care settings, the instability and rapid changes of the person who's more acutely ill, it may require that it's updated daily or even more than once a daily at shift changes or, more often than that, even if necessary. Residential levels should formally review progress once a week and more often if the person is quite unstable. So there's more information about the book about different levels of care and how often the treatment plan should be reviewed. And I know we talked about earlier that really it should be reviewed as regularly as appropriate given the person's severity, level of function, and level of care, as well as their treatment needs and their wants and desires. We'll talk in a minute about continued service and what that criteria looks like, but the treatment plan could be updated if the person, is maybe in treatment for a while and then lets the clinician know that, they do have a history of trauma that, now they're ready to start working on, or they want to add something to their treatment plan, or, a new problem has come up for them in their life, maybe CPS is involved or now they're involved and requiring something of them. So they may want to add goals and things into their treatment plan, they may change the course of treatment a little bit, which also takes me back to the question we had earlier about determining how long someone would be in treatment, whether it's, 14 days, 30 days, 90 days. So that's another reason why it can't really be determined up front, because when someone's in treatment, new things may come up or, they may meet their goals faster than they even anticipated. So really that's why it needs to be individualized and looked at as treatment goes on and as they progress to their goals. Next slide, please. Okay, so take a minute and think about what your program's criteria is for continuing care, transfer, or discharge of someone. So just take a minute and think about that. What are some of the things that you consider when you're trying to make that decision? Another thing, so say you work in an outpatient setting and, the end of the authorization period has come. So what is it that you do to determine that more treatment is needed for someone versus maybe transitioning them to a different level of care or to community resources? Okay, so it's likely that, review of the treatment plan takes place. So you look at their progress with the goals that they have, you would assess their needs, and, all of that information would be a factor in how you make your decision. But I also want to emphasize here that going back to the treatment plan, that's why it's essential that clear, measurable, treatment plan goals and objectives are noted that correspond with the admission criteria so that you can effectively utilize that to look at, their progress and do they need continued service? Are they ready for a transfer or discharge? And it also, like I said, kind of does go back to what we talked about early this morning about the paradigm shift. So fixed length of stay programs wouldn't be consistent with individualized or person-centered or outcomes-driven treatment. So I guess an example of that would be, if there's a 30-day residential program, but the person, meets their goals on day 18 and they're ready for discharge. So they would be, they could have completed that program, they've completed their goals, they're ready for transfer, and if the program says, 30 days is what you have to do to complete treatment, they may not need those additional days. Okay, and then I'm seeing some comments in the chat about assessing needs, consulting with the individual for their needs. Exactly. So seeing, how they're feeling and where they're at with treatment, if they feel they've met their goals and what their plans are from here. Looking at the stage that the client is in, motivation level, attendance of services, and treatment goals assessed. Yeah, exactly. Okay, and the next slide, please. Okay, so this is the continued service criteria for ASAM. So this can be found in the book. There's 3 different criteria as shown here, and they would just need to meet one of these 3 points for continued service to meet criteria. So the first bullet considers where the person is at with making progress. So maybe they're making progress, but they haven't yet achieved all of their goals, so they could need continued treatment. The second bullet considers, is the person making progress or not making progress, but has the capacity to do so. So they're able to make some progress in that current level of care. They just maybe haven't yet. And then the third bullet point considers, if the person has new problems that have been identified that can be treated at the present level of care. So that may require continued service. So I just talked about that a little bit where, if they're in treatment and then they let you know that there's this other goal that they're working on or something new has come up and now they need to continue in treatment to work on that. Okay, so to determine this, you would apply the criteria to each of the 6 dimensions that we went over earlier. And you would look at each of those areas and then assess where the person's needs are. And remember, with the ASAM, pay attention to the words and or, because here, or is indicated. So it means that only one of these need to be present, not all of them. Okay, next slide, please. Okay, so transfer or discharge criteria. So here we're looking at criteria for transfer either to a more or less intensive level of care or a different type of care or discharge. So this would be the criteria noted for that. So A, the person has achieved their goals in the treatment plan. B, they've been unable to resolve their problems. C, they've demonstrated a lack of capacity to resolve problems. D, the person has experienced intensification of problems. So with these, some may indicate that they're ready for discharge or transfer to a lower level of care, and some could be that they just need, a different level of care, a higher level of care, or other supports and services to help them meet their goals. Okay, and next slide, please. Okay, and this is just the bidirectional continuum. So when looking at continued service, transfer, or discharge, people do not necessarily move through the levels in a linear manner. So they might move up and down in levels of care, depending on their level of severity and function, which is often not in a linear manner. So really, their course of treatment is individualized based on their specific needs. It could look different for every person. And next slide, please. Okay, so we're just going to talk about documenting continued service, transfer, discharge. So documentation can reflect the rationale for either continuing treatment at the current level or for moving to another level of care, but it should include the rationale and it should indicate how you came to that decision and why that decision was made. It should also explain the person's progress in resolving their issues identified in the treatment plan, and then include what's been achieved. So which goals and objectives did the person meet, and what has occurred in treatment. Okay, next slide, please. And so here are some questions you might consider when you're documenting continued service, transfer, or discharge. So are there new objectives? Are there new problems? What objectives or goals need to be achieved to support discharge or transfer? And then based on the treatment plan, why does the person need to continue in treatment? Or, what are they working on in treatment? Some of you may be familiar with the reauthorization process for continued stay and continued treatment. And so it may sound familiar that documentation and requests for continued stay needs to be detailed. So really with those, UM is looking for specific detailed information. Examples or as evidenced by information could support that request. And it's essential that this is thorough in the documentation to support the decision being made, whether it's any of these things, continued services, transfer, or discharge. And then the same goes for progress. If progress is noted, include the treatment plan goals and the person's progress towards achieving those goals. And that you would want to include in your, any documentation, but also in your continued service request. So it's important to note, how treatment has been going for this person, why it's working well, or maybe why it's not, and then what steps will be taken or what plans will be put into place, and then how we'll help them move forward. Okay, and then so typically people are transferred to a more intensive level of care when they aren't progressing at the current level, but sometimes a different type of care may be needed. So for example, co-occurring services may need to be added in. Megan mentioned, peer support services, or maybe a CBT model versus 12-step program, something like that. So those are all things to be taken into consideration when trying to determine an appropriate transfer. Okay, and then I see a comment from Stacy. Even in my ASAM, I say person being served reports no withdrawal, not client, helps dissolve and implement person first language. Yes. Yep, exactly. Okay, special populations. So these are our last couple of slides, and we're not going to go in depth. We're just going to talk briefly about the different populations. So there is a chapter in the 3rd edition of the ASAM criteria that's devoted to special populations or groups such as older adults, criminal justice settings, parents, prospective parents, and then people in safety sensitive occupations. So this is chapter 7. They have guidelines in the book for providing services with these populations, and then Chapter 8 also provides considerations such as admission criteria and other factors involved with unique needs to ease the use of ASAM criteria with these groups. So we just wanted to note that there is additional information in the book about these populations. If you are completing an ASAM for them and feel, that, there's other factors that you want to make sure are included, the book will go over that. And next slide, please. And then, so criminal justice, the 3 C's. So again, here we're only briefly going to talk about this, and we're looking at the 3 C's: consequences, compliance, and control. So consequences, it is within criminal justice's mission to ensure that offenders take the consequences of their legal behavior. If the court agrees that the behavior was largely caused by addiction and/or mental illness, and that the offender and public are best served by providing treatment rather than punishment, then clinicians provide treatment, not custody and incarceration. The obligation of clinicians is to ensure a person adheres to treatment, not to enforce consequences in compliance with court orders. In compliance, the offender is required to act in accordance with the court's orders, rules, and regulations. Criminal justice personnel should expect compliance, but clinicians are providing treatment where the focus is not on compliance to court orders. So the focus is on whether there's a disorder needing treatment, and if there is, the expectation is for adherence to treatment, not compliance with, doing time in a treatment place. And then lastly, control. The criminal justice system aims to control, if not eliminate, illegal acts that threaten the public. While control is appropriate for the courts, clinicians and treatment programs are focused on collaborative treatment and attracting people into recovery. The only time clinicians are required to control a person is if he or she is in imminent danger of harm to self or others. Otherwise, as soon as that imminent danger is stabilized, treatment resumes with a focus on collaboration and client empowerment, not consequences, compliance, and control. So working in the criminal justice system involves respecting the different roles of public safety and public health while working to integrate services. It's the clinician's responsibility to determine appropriate length of stay and level of care. So the service provider is accountable for the clinical rationale for services and the length of stay recommended based on the person's clinical needs. So it's important here not to lose sight of clinical expertise and obligations when criminal justice is a factor. And there is more about this in the book as well. And so this does conclude our training with all of you. We want to take some time now before we wrap up for any questions you may have. I know there's been questions throughout, but if there's any others that you have, feel free to let us know. We are happy to answer them. And then if you do think of any even after the training, feel free to reach out to Megan or to me. We're happy to help you with those. So feel free to type anything in the chat or unmute. We want to hear if you have any questions.
And I want to say a big thank you to everyone. Thank you for joining us, and thank you for just rolling with our quick changes. And this is our first time presenting this, so we immediately said, oh, we're going through quicker. Let's make a quick adjustment. And so I thank you all for hanging in there, and you will get half your day back tomorrow then as well.